organizations in collaboration with the Sri Lanka College of Pulmonologists to commemorate World COPD Day. This marks the last specialty update of the year. The specialty update on respiratory medicine has been a continuing event in the academic calendar, providing a platform to bring together experts in respiratory medicine to engage in discussion and share updated knowledge. COPD is a leading cause of morbidity and mortality worldwide, responsible for a significant disease burden both for patients and healthcare systems. The condition, which includes chronic bronchitis and emphysema, leads to progressive airflow limitations and severe respiratory symptoms, impairing patients' quality of life. COPD is often underdiagnosed in its early stages and remains a major driver of hospitalizations, disability, and healthcare costs globally. For the medical community, staying updated on the latest research, treatment guidelines, and management strategies for COPD is essential. By enhancing knowledge, healthcare providers can improve early detection, optimize treatment plans, and educate patients on lifestyle modifications to slow disease progression. Moreover, updating knowledge on COPD helps to address the growing disease burden by ensuring that clinicians provide evidence-based care, reduce complications, and ultimately improve both patient outcomes and the efficiency of the healthcare system. And this specialty update today, ladies and gentlemen, will provide the ideal platform with the participation of experts in respiratory medicine all in one forum. To commence today's proceedings and to welcome all of you on behalf of the Ceylon College of Physicians, I would now like to invite the President of the College, Professor Prasad Katulanda.
Good morning, ladies and gentlemen. President, College of Pulmonologists, Dr. Neranjan Dissanayake, and the immediate past president of Ceylon College of Physicians, Dr. Upul Dissanayake, and senior pulmonologists, past presidents, and members of the College of Pulmonologists and members of the Ceylon College of Physicians, ladies and gentlemen. I take immense pleasure as the President of the Ceylon College of Physicians. This is my first official function to welcome all of you to this respiratory update organized by the Ceylon College of Physicians in collaboration with the Sri Lanka College of Pulmonologists to commemorate the COPD Day 2024, which is a very important, I think, function in terms of pulmonology in Sri Lanka as well as the entire world. And I see an excellent program drawn by the College of Pulmonologists, and also where a galaxy of expert pulmonologists are speaking on different aspects of COPD, from diagnosis, classification to management and other aspects, where both will lead to improvement of our understanding and management of COPD, not only by the pulmonologists but also by general physicians as well as by other doctors. So I appreciate all of you. Particularly, I would like to thank Dr. Upul Dissanayake, Chiranthi, and the other members of the council who really were behind organizing this, along with the College of Pulmonologists, and also Dr. Sandeepana Gamage and Dr. Wathsala Gunasinghe, who were also involved in organizing this event. I think we have 2 hours of deliberations on COPD, and it will be a very fruitful exercise. Thank you very much.
Without further ado, we'd like to now move on to the first panel discussion. I would now like to invite the panelists, Dr. Amita Fernando, Consultant Respiratory Physician, National Hospital of Sri Lanka; Dr. Neranjan Dissanayake, Consultant Respiratory Physician, Teaching Hospital, Kalutara; Dr. Wathsala Gunasinghe, Consultant Respiratory Physician, District General Hospital, Negombo; and Dr. Kanthi Nanayakkara, Consultant Virologist and Vaccinologist of the Medical Research Institute; and Dr. V.M. Ransun K. Madhusankar, SR, the Senior Registrar in Respiratory Medicine, to commence the first panel discussion.
Good morning, everyone. Thank you for giving us the opportunity to give this case-based discussion on chronic obstructive pulmonary disease. Thank you, CCP and the College of Pulmonologists. And today we'll review a real-world case scenario to explore the diagnostic process and the management decisions and the long-term care guided by the evidence-based practice. This is 68-year-old man who initially presented in 2 years back with exceptional shortness of breath. It was classified as NIHA class 2 and it was initially evaluated at the cardiology unit. As there's no evidence of cardiac events, there's no source of cardiac cause for this shortness. They referred the physician to get further on this exceptional shortness of breath. So the key respiratory symptoms patient had was this daily productive cough with mucoid sputum for the last 2 months. Otherwise, he denies any nocturnal symptoms. There's no variation in the postural change with the postural changes, and notably, he doesn't meet for the criteria for the chronic bronchitis. And there was no associated symptoms suggestive of any upper airway involvement, no gastroesophageal reflux disease symptoms, and there are no features for TB which are suggested by hemoptysis, and there's no other features for the connective tissue disease features. Apart from that, there's no history of recurrent chest infections or pneumonias, and no previous history of inhaler use, and never on a nebulization. And there's no past history of TB, and there's no past contact history also. Only comorbidities patients having this diabetes for 2 years and hypertension. Only he is on losartan, but not on any ACE inhibitors. So I would like to describe more on the social history, which is remarkable in this patient. He is a manual laborer with significant exposure to this dusty environment. Daily exposure to this dusty environment, and he's having this 10-pack years history of cigarette smoking and this long-lasting substance abuse history for about 30 years. Otherwise, there's no biomass exposures or organic dust exposures. So on examination of this patient, he's not dyspneic at rest, and we noticed that he's having increased anteroposterior chest diameter. And otherwise, there's no features of connective tissue disease, no clinical signs of pulmonary hypertension, and no evidence of heart failure. On lung examination, we noticed that patients having polyphonic bronchi and they are short in expected time, which is more suggestive of obstructive airway disease. In this patient, BMI was around 28. So this highlights that this heterogeneity of COPD. Not all patients are always cachexy. So we come to conclude differential diagnosis. So first one is COPD with the significant smoking history and this occupational exposure, and maybe the smoking related ILD also a possibility, but we would like to exclude with the imaging, and bronchiectasis also we like to exclude with the imaging, and heart failure already excluded by the cardiology team, and with this significant exposures of smoking we would like to exclude the lung malignancy also. So the investigation wise, he was previously evaluated by the cardiology team. Almost all investigation done for this exceptional SOB. Even the coronary angiogram also normal, and it suggests of no coronary artery disease. So we did the infectious screening part. So TB, tuberculosis, we excluded with the sputum studies. And this basic investigation, mainly this full blood count, even though it's normal, differential wise, absolute count of eosinophil around 400. That will give a clue to our therapeutic approach. ESR also for around 48. This is the chest X-ray of this patient that shows hyperinflated lungs with flattened diaphragm and this vertical heart, and there's increased radiolucency. So this give another clue that patient may be having some obstructive airway disease. So we go ahead with the HRCT. So that shows bilateral scattered central lobular emphysema. Otherwise, there's no features of ILD, no features of bronchiectasis, or no features suggestive of any malignancies. So this is the first spirometry. If I go through the values, this FVC value is around 80% predicted, FVV1 value is around 58% predicted. So the ratio is around 73%, around 57%. Unfortunately, that time we couldn't get the bronchodilator reversibility. So I would like to ask from our madam, so what do you think about this spirometric diagnosis and this COPD patient?
I think Dr. Neranjan is going first, right? So the college and Dr. Neranjan and his team wanted to make this more interactive so that we can have a discussion. So we have, Rasun mentioned several things about some factors contributing to the possible things. So Neranjan, whom do you think is a COPD suspect? In whom should we suspect COPD?
Thank you very much for that elaborative presentation. I think making the stage for a very good discussion, and thank you very much, sir, for your question. And I think the landscape of COPD is changing, whom we should suspect, what we should do, and whether we should do something more than what we are doing at the moment. I think those are the pertinent questions that we have regarding COPD management. My mind goes back to about 20 years back when I was a house officer, probably 22 years back. When a patient with COPD comes, we had very few options to manage these patients: aminophylline drip, hydrocortisone, antibiotics, and oxygen, and wish for the best. And none of the ICUs will probably accept these patients for further care. And unfortunately, majority of them would die within the next few days or within the next few months. But now I think there is a significant change in the management of COPD that has improved morbidity as well as mortality in COPD patients. So hence, how we should diagnose COPD, do we need to do something more, is a very important question. Right. So when we look at COPD, obstructive airway disease, the definition of COPD, it's mandatory that we prove that the FE1 to FEC ratio is less than 0.7. So that is one of the hallmarks of diagnosing COPD in patients, and that itself explains the explanation of the obstructive airway disease that the patient is having. So in this patient, I think you can see that the FE1 to FEC ratio is about 61%. And when you look at the reversibility, again, it will be very low. Hence, this patient is having a FE1 to FEC ratio of about less than 0.7. And a COPD diagnosis can be entertained in these patients. So this is one of the mandatory requirements in diagnosing in COPD, and it has not changed even in the 2024 guidelines as well. But what do we understand about COPD now? When we have this mandatory criteria, we have to have a exposure history that might predispose these patients for COPD. And we know from the 50s and 60s, smoking has been identified as a significant risk factor of COPD, and it is still, but there is change in the understanding at the moment. So smoking is not only the cause. And this famous graph that we have done by Fleischer and Peto explains that the fact that when you start smoking, your lung function significantly deteriorates, and from a starting value of FE1 value of about 100%, that is the maximum that you can achieve in the age group, and then you gradually deteriorate anyway when you age, but when you start smoking, it gradually deteriorates faster, and then if you stop smoking, there is a improvement in your lung function. So this is the one that we accepted for the past 50 years. Is it the same, or has it changed? We will see, right? So with the understanding of the pathophysiology of the COPD, we know that there are two main components that are affected in the COPD. The bronchi, the small airways, where there will be inflammation, mainly a neutrophilic inflammation as a response to the inhaled irritable substances that we are inhaling, and then the emphysema, which is a damage to the lung parenchyma, and the combination of both will cause the phenotypes that we have already known in COPD, the blue bloater, which has a prominent pulmonary hypertension type with a chronic bronchitis predominant type, as well as the emphysematous type with the pink puffer. So, and our understanding as well as the availability of non-invasive ventilation and further has improved during the last years regarding COPD, but unfortunately, as our senior registrar colleague has explained, unfortunately, these patients comes to us at a very, very late stage in COPD. And that is why I think Sir wanted to clarify these problems further. So these patients come to at a later stage, and majority of the patients with COPD, about 70% come at stage 3 and 4, like the patient that was described. And unfortunately, 50% of them, after one exacerbation, will die within the next four years, unfortunately. So there is a late presentation of patients coming, and their outcomes are very poor when we diagnose at this stage. So can we do something about it? Right. So when we look at the definition of COPD, again, obstructive airway disease, it's a heterogeneous disease, and the diagnosis basically, as we discussed, is FEV1 to FVC ratio of less than 7. So if it is less than 7, we have to do the post-bronchodilator test. And if it persists to be less than 0.7, then we can conclude and confirm a diagnosis of COPD. But when the FEV1 to FVC ratio is more than 0.7, probably it is not COPD, but we have to again do the bronchodilator test, where it might be FEV1 to FVC if there's a volume responder, or sometimes there might be a low FEV1, or when patient might have high symptoms. So it is very important to do a reversibility test at this time. Right. Depending on the obstruction, earlier we assessed the severity. So thinking that it is a fixed airway obstruction, so obviously the FEV1 value would tell us the severity of the disease. Hence this GOLD categorization of airway obstruction severity, GOLD 1, 2, 3 and 4, the 30, 50, 80 rule, as all of us know. But unfortunately, even though this classification tells us about the severity of the obstruction, but unfortunately, sometimes this doesn't tally with the symptomatology. But these categorizations are very important. The most important aspect of this categorization is, as we can see, stage 3 and stage 4 GOLD, especially the number of small airways in the lung are completely more significantly destructed than in GOLD 1 and 2. And when we look at the terminal bronchioles as well, there's a significant destruction of small airways. So it doesn't not only affect the small airways, it affects the bronchioles and beyond the bronchioles as well. And especially this FE1 value will correlate markedly with the airway destruction, especially the small airway and the terminal bronchiole destruction. So this categorization has some value, even though it might not correlate with the symptomatology. And when we look at further in these patients, we can see that when you look at the GOLD 4 category, there will be increasing amount of cells, increasing amount of B cells. And when you look at the fourth, the lowest one, there will be increasing amount of lymphoid aggregations in these patients in COPD, signifying that these stage 3 and 4 are rather pathologically different from stage 1 and 2, where especially when we have the lymphoid follicles there is a certain autoimmune process that is going on, and these cells, when they are isolated and they are challenged with elastine and other substances in the lung parenchyma, these create an interferon gamma response, suggesting that the adaptive immune system in stage 3 and stage 4 COPD is different. So even though again, stage 3 and stage 4 might not correlate clinically, it has some pathophysiologic importance when we are thinking about managing these patients. So causes and risk factors, we thought smoking was the only factor, but it is the getonomics actually. The getonomics means the gene, environment, and time. There are multifactorial involvement, and we know that the only gene that has been proven is the SERPINA gene. This is the alpha-1 antitrypsin, which causes alpha-1 antitrypsin deficiency in the chromosomal 14. But there are multiple genes that have been implicated in the pathogenesis of COPD. So now we know that there are multiple genes that are affecting the COPD, and when these genomics are having a risk of creating COPD in the patients, we can understand that from in utero, these genomics starts, and then the epigenomics starts, and then the transcription factors are different. So COPD actually probably starts at the day of conception rather than starting smoking at around age 25. So some people are at risk for this. So this this genomic theory, getonomics theory says that as time progresses, these genes differ according to the time, because various genes become activated with time, and that various exposures that we have, maybe occupational exposure, biomass exposure, or smoking, can cause changes in this epigenetic structure. And then again, with time, with the normal aging process as well, there is a significant change in the COPD pathogenesis and the progression of COPD. So there is a difference in the understanding that we have regarding COPD. Hence, this graph is now changed to this graph. Some people start at the conception with a low FE1 level, which might not peak at the 25 age group as a normal person, and then some of them might have a rapidly deteriorating FE1, maybe due to exposure, maybe due to other factors, but some of them might have a normal reduction of the lung function that is expected. So it is not very simple that previously thought. And again, to make this more complicated, some people might have a higher FE1 at birth, and they will peak at around 120 of the FE1. And the importance of this group of people is they might have a normal, within brackets, when we check the FE1 to FEV1 ratio, but actually there might be a significant deterioration of their lung function compared to the normal. So we might miss a certain group of people if we just look at the FE1 value and the FE1 FE2 ratio. Right. So these are actually called supranormal, normal, pseudonormal, below normal, early decline period. So these aspects are very important when we are thinking about that. So there are many etiological factors which are now coming into the COPD guidelines, the GORD guidelines. We have the genetically determined COPD, COPD-G. We have COPD-D due to abnormal lung development. We have environmental COPD, COPD-C. We have biomass and air pollution, COPD-P. And we have infection, COPD-I, which is in Sri Lanka. It is a very common post-TB and post-infective bronchiectasis and other conditions giving rise to this condition, especially when the patient is exposed to biomass fuel, which is again a different type of a thing, because they have a very high, sometimes they have a high IgE level, they have some aspect of bronchiectasis in them, and they have increased eosinophilic levels rather than the typical smoking related COPD. So we are dealing with some phenotypic deviations in the COPD outline, right? So because of that, I think this is the question, sir, you asked. Early COPD, it indicates that it is in the near beginning, and probably we can diagnose them at around age 25 and further with improved diagnostics. And then we have the mild COPD, which is not very well encouraged. We say it early COPD rather than mild COPD, because COPD is not a mild disease, and even a mild saying disease can cause exacerbations. COPD in young patients is a fixed airway obstruction in patients who are less than 50 years, 20 to 50 years. And then we have this concept called pre-COPD, where even though the FE1 to FEC ratio is more than 70% or 0.7, there are changes in these patients, such as symptoms of dyspnea will be there. There will be structural abnormalities in the CT, and there will be low DLCO and hyperinflation in the lungs. So these are what we call pre-COPD cohort of people. And there are certain groups: mild COPD, young COPD, early COPD, and importantly the PRISM, where preserved there is preserved what do you call this? Sorry. Preserved ratio with impaired spirometry, where you can have a new category of people coming into the COPD picture. So what is basically PRISM? It's a very important aspect where these patients FE1 to FEC ratio will be more than 70%, but their post-bronchodilator FE1 percentage predicted will be lower than 80%. And about 14% of the cohorts will have PRISM. What is the clinical significance? They have divided PRISM into 3 clusters, where the restrictive pattern, which has cluster 1, we call the cluster 2 is the COPD pattern. Cluster 3 is the BMI pattern, where the patients will have a high BMI, increased metabolic burden, and they are more symptomatic than the typical cluster 2 of PRISM. So even though the FE1 FEC ratio is more than 70%, there is a subgroup of people will have features of COPD, and there we'll have certain implications like shown in this graph, where some people with gold prism might go into gold 0, and some people might go into actually obstructed airways as well. So there had been a two-way progression in the PRISM group. So that is very important to understand that even though this group is what we call a pre-COPD group, some of them might improve, some of them might deteriorate. And the biomarkers that will predict deterioration are currently under investigation. Right? Hence, the severity we assess with the FE1 to FE1's ratio is 0.7, and then we according to the FE1 ratio. But how this affects the person is the most important thing that we have to see. Even though gold 3 and 4 have some correlations between the severity, the airways, number of airways disrupted, but it doesn't correlate with the symptomatology of the patient. One suggested one is the MMRC grades of a person, but it looks only at the dyspnea. Hence, the best correlation of symptoms is what we call the CAT score, and the St. George's questionnaire is another very important one, but it is very cumbersome to use. But in the clinical aspect, this CAT score will have majority of the symptomatology, and it will give you a clear idea about the patient characteristics and how it affects the patient rather than a simple MMRC score. So a CAT score of about 10 will be St. George's score about 25. It is one that is advised in the gold new guideline as well. You can use the MMRC score, but it is a better assessment of the patient's symptomatology of our patients. Right. So then, depending on that, we go into whether this patient is having A, B or E category. A is when you have a MMRC score of 0 to 1, and then B is MMRC score of more than 2 or CAT score of more than 10. So then we decide into A and B, and if this patient is having more than 2 moderate exacerbations or more than 1 leading to hospitalization, this patient becomes simply E exacerbator. This is different from the C and D group that were there in the previous gold guidelines. So now we are actually looking at exacerbations rather than the CAT score, especially because of the exacerbations. And I think Ruwanthi will tell you why the exacerbations are so important, because we are giving a highlight to the exacerbations rather than the CAT score, rather than anything else, and rather than the gold category as well. So, dear friends, basically now, as we understood, COPD simply is not a disease that is a simple disease, that a self-inflicted disease of the lungs which cause chronic obstructive airway disease. It's a complicated disease which has multiple causes, starting in utero and then progressing into the adulthood and causing significant comorbidities in most of our adults. And it is basically a gene, environment, time response to a harm that is happening in a chronic way to the lungs and the lungs that we breathe. Thank you very much.
Before we move on, I think Neranjan's slides nicely illustrated the early life origins of COPD. Earlier classifications spoke of COPD as a preventable disease. Now we seem to be move on to disease heterogeneity and identifying these treatable traits, to say so, to identify these treatable traits so that we can identify certain etiotypes, as you mentioned, which might need specific interventions, and they may have specific clusters, as you mentioned, and also a specific biomarker like the eosinophil later on in life. Yes, so things like the pre-COPD and things, just to clarify, some of these patients have radiological changes but do not meet, like they have chest X-ray, HRCT changes, but they do not have, they do not fulfill the spirometric criteria, right, of COPD.
Yes.
In such instances also, what would your approach be to such patients?
I think the most important thing is when you see a radiological damage, that means the damage has already happened. So the process of COPD is a chronic one, which goes on and on and on. One insult triggers another insult, and that goes on and goes like interstitial lung diseases. So especially a single trigger will cause a disease. So if we see a significant radiological abnormality or pathological abnormality, even if the patient has undergone biopsy or another person, I think these patients probably should be started on treatments as COPD COPD as early as possible, even though the FEV1 to FVC ratio is not criteria is not fulfilled, because sometimes we know that these criteria are very strict, and we know, and Professor Katulanda is here. So basically, the fasting blood sugar, the cutoff, some people start deteriorating, having microvascular complications even with a fasting blood sugar of less than 100. But some people might not have these changes even at 120. So I think if we can see significant end-stage damage or end-organ damage, I think it is better to consider that.
In the interest of time, just a final question.
Yes.
You highlighted the importance of spirometry.
Yes.
And the spirometry initially, if you have an obstructive defect on your spirometry, then you have to proceed with the post-bronchodilator values. In screening, do you always need to do a post-bronchodilator spirometry, or is it if you have obstructive pathology, you show the algorithm?
Yes.
Where in some patients you may have to proceed in, though the spirometry is normal.
Normal, yes.
Though the spirometry is normal, you may have to do a post-bronchodilator study.
Yes.
So is that the case always, or just you go to do the bronchodilator spirometry if you have obstructive pathology?
Basically, sir, now, if it is basically less than 0.7, I think we can be assured. Especially the only thing that we have to exclude is when it's a transient bronchoconstriction, especially in the young age group, whether we are missing any asthma. But if it is, if it is more than 0.7, but still in certain groups that we discussed today, we can't completely exclude COPD, because we might be able to diagnose certain people with early COPD after the bronchodilator response. So I think especially if the patient is having significant symptoms and have high exposure levels, maybe we might be able to do these ones. Especially, I think the lung function expert is here, the Dilesha is here. So basically, FEV1 to FVC ratio probably can be reduced even if you have a low FVC, isn't it? Right? So sometimes there might be false air trapping causing this one, because these patients might have small airway collapse at the early stages, and it might cause a normal value sometimes. If you want FVC might be normal in these patients. And we have this high performance, that means pseudo normalization, where earlier the patients will have a high FVC value, FEV1 value, and they might come back to the normal. So some of these patients might be able to diagnose, and I think probably we might be able to go ahead with the total lung capacity in these patients to identify whether these patients is an air trapper, and whether, especially oscillometry, we might tell us where these patients will have a small airway disease. So in this age group, I think we have to, especially when there is a significant exposure, when this patient is having symptoms suggestive of COPD, and or plus or minus when there are radiological evidence to say that this patient is having damage, probably we might have to go further rather than sticking to the FEV1 to FVC ratio.
Right, rather than the fixed ratio.
Thank you.
Okay, I think Rasun is divulgate, right?
We'll be discussing this. So just to add to that, I think as a population, screening is not recommended, so generally guideline-wise. If you are doing a screening like
doing spirometry for a population?
to diagnose COPD, but still if you are doing, initially if you are doing like in a health camp or so, then probably it's just pre-bronchodilator values are fine.
Fine. Post-bronchodilator.
So I think we'll go to the management part.
We'll go to the
Yes.
Yeah.
So as Sir nicely described, so we also assess this patient. So MMRC score is in this patient is around 1, and CAT score is less than 10, it's around 8, and there's no previous exacerbation history. So we can assess the severity. So initially, this 2 years back, he was in COPD A category. So then we started on treatment of this patient. So first of all, we have to quit his smoking habit. So the smoking cessation is the mandatory part in this management. So first we referred this patient to substance abuse clinic, and with that his cough and sputum production markedly improved, but some symptoms are still there. So we started him on bronchodilator therapy with the LAM, initially with the LAMA therapy with mainly dipyronic capsule, tiotropium, and if we needed only, we give him MDS, salbutamol inhalers. So we continuously followed up over the next 3 months. So still he's having some dyspnea symptoms with MMRC grade 3 and CAT score remained around 8, but still as patient still symptomatic. So we reassess the patient and we assess the patient's inhaler techniques and whether the patient's pharmaco adherence was satisfactory or not. However, the patient was pharmacology, we can improve with the symptoms. So madam will discuss further on the management of this stable COPD patient. Thank you.
Thank you, Kaswan. When we manage now, this patient is stable. Initially, we diagnosed, and now we are going to manage. So, what are our goals? So, when we are managing a patient with COPD, we have what are our treatment goals? So, COPD is not a curable disease. So, then we want to, on one hand, we want to relieve the symptoms. And also, that means if they are dyspneic, we want to reduce the dyspnea. And also, we want to improve the exercise tolerance and as well as improve the health status of the patient. In addition, we want to reduce the risk. That means we want to reduce the disease progression, reduce the exacerbation, and reduce the mortality if it is possible. So we'll be discussing about this. So when we manage COPD patients at any stage, we discuss about the severity classification and the spirometry severity assessment. So any patient, you have to realize that it is not only pharmacology. Pharmacological treatment has a cornerstone, as well as we have to adhere to certain non-pharmacological interventions, and we have to apply to whatever the relevant category to the relevant patients. And also in the non-pharmacological interventions group, sometimes we will refer this patient for further treatment, like advanced treatment like surgery or bronchoscopic interventions. So we'll have a look at the pharmacological management. So there are 3 categories of groups of treatment that you can use. So one is bronchodilators. All of us know about bronchodilators. We have short-acting beta agonist as well as short-acting muscarinic antagonists like ipratropium, and we have LABA, long-acting beta agonist, and LAMA. So all of you know about these acronyms, so I will use them. So LAMA, tiotropium is the one that we commonly use, but there are newer preparation with some long-acting like actinium, glycopyrronium, and so on. And under bronchodilators, there are methylxanthines as well. That is your common use, theophylline. We'll discuss on those. Then anti-inflammatory agents. What are the anti-inflammatory agents? Inhaled corticosteroids are there. Oral corticosteroids are there in severe category of patients. The severe patients we can use. And more newer, we don't have it in Sri Lanka, but we have PDE inhibitors, PDE4 inhibitors like rofimilast, and there are now in the recent guidelines, it mentions about PDE3 and 4 inhibitors, combined inhibitors as well, which is enicephalintine. And also we can use antibiotics, azithromycin long term, and also biologics. Dupilumab has come, and that is in the GOLD guidelines now. Mucolytics have a certain part to play. And of course, we are all interested in these combinations because combinations give better adherence and all. So LAMA and LABA combinations are there, as well as ICS, LAMA, LABA combinations. So I thought you will be interested to know about LAMA combinations. So these olendroterol, indacaterol, and vilanterol, those are like ultra long-acting beta agonists, and they can be combined with LAMA, and these are the inhaler types. Currently, I don't think we have it in the market in Sri Lanka, but sometime back we used to have. Then this ICS LABA-LAMA combinations are there, which are highly promoted all over the world. You can see this trilogy ellipta that has fluticasone with umeclidinium and vilanterol, which acts for 24 hours. So most of them have a fairly long-acting once daily usage. So if you look at bronchodilators in stable COPD goal guidelines, it gives lot of statements. It's sometimes confusing as well, but if you want to summarize, I think this is the best way of summarizing. So you can use short-acting agents, SAMA or SABA. They will improve symptoms and useful in immediate relief. But generally, as you know, regular short-acting antimuscarinic antagonists like ipratropium, regular use is not recommended because increase in cardiovascular risk in COPD patients. Both LABA and LAMA is recommended and improve parameters, and LAMA is better in exacerbation prevention if you compare with LABA, like long-acting beta agonist. And always combinations are preferred and better than monotherapy because they reduce the exacerbation and improve FEV1. And our old theophylline also has modest symptomatic benefits. Now we are interested and we always query why can't we get down all these triple combinations and all. But you have to realize one thing, they are good in adherence and also patient perceived outcomes are better, but the treatment effect, there's no difference. Like if you give 3 individually, or you can use, we have commonly long-acting beta agonist plus ICS combination is available. So with that, if you add a long-acting antimuscarinic agents like tiotropium, so the treatment effect will be same or more. So treatment effect, there's no difference, but patient preference and adherence is better if you put all of them together. So which therapies to consider? So when you are having a patient with COPD and you want to start him on the pharmacotherapy, you have to consider, as we saw, the severity of the airflow obstruction and nature and magnitude of current symptoms, previous history of moderate and severe exacerbations, blood eosinophil count is very important, as well as presence and type of other diseases, like what are the multi-morbidity. So this is the goal guideline. You can see the severity assessment we discussed earlier. So group A, group B and group P are there. And group A, it's a bronchodilator recommended. So it's you can use a short-acting agents or if it is affordable and available, you can use a long-acting agent in group A. That is patients with like minimal exacerbations and minimal symptoms. And group B, where there's more symptomatic patients but not very high exacerbations, then the combination is the one that is recommended, that is LABA and a LAMA combination. It will give a better symptomatic control as well as lung function improvement. But still, if you don't have the combination, so if it's not available, you can choose one of these. Then when you go to group E category, where the patient is more having recurrent exacerbations, more than 2 moderate exacerbations or more, one or more leading to hospitalization, that is a patient who is prone to exacerbation. So in that category also, initially LAMA-LABA combination is the one that is recommended, and you can combine with the inhaled corticosteroid in a certain category of patients, especially we consider the blood eosinophil count. We'll have a look. So if you want to add ICS to LAMA-LABA combination, so the category of patients you can, the strongly recommended category of patients are the patients with high risk of exacerbations or frequent exacerbator with blood eosinophil count more than 300. Now our patient, I think he had, we'll discuss our patient. So blood eosinophil 300, that is a strong recommendation, as well as if the patient has concomitant asthma. That is obvious. All the asthmatic patients, you have to give inhaled corticosteroids. You don't keep them without inhaled corticosteroids. So that is a strongly favor use. Then the second category is favor use, because then that is if they are having one moderate exacerbation of COPD a year with a blood eosinophil count between 100 to 300. So, but against use, why we are worried of ICS, there are, although we say minimums have problems, but with inhaled corticosteroids, there are issues. So, mainly in COPD patients, there's a risk of pneumonia. So, if the patient has repeated pneumonia events, then you are not going to add the ICS. Also, blood eosinophil count, the red section, if it is less than 100, probably there won't be much use in that patient. And also if there's a history of mycobacterial infection. So when we describe the different categories of COPD, even after post-infection or so, we can get COPD. So in those groups of patients, we have to be a little bit careful. So this patient, MMRC, initially, it was 1, I think. Exacerbation was also not very frequent, and CAT score was 8. E count was 400. So where does it fall? So if you just ignore the eosinophil count and you consider the COPD exacerbations and MMRC, is a group A patient. So ICS here, he is needing initially is a bronchodilator, because ICS, although his E count is little bit higher, you have to be mindful E count be high due to different reasons. So in our context, parasitic infection and all that, and always the guideline mentions you have to see it as a continuum, like persistent high eosinophil count, not just one standing alone. And here also you add ICS to treatment, that is group E, that is for the patients with frequent exacerbations. So this patient doesn't have exacerbations, so this patient doesn't need, at this point, he does not need a ICS, so he can be managed with a bronchodilator. I think our patient was given tiotropium plus salbutamol rescue medicine, so that is fair enough. So few points regarding what to consider when you are choosing an inhaler, because we have seen so many patients, we see so many patients being given proper inhaler but not properly being used. So you have to, before prescribing something, you have to assess the patient's ability to use the device and lifestyle and circumstances. We sometimes prescribe a spacer, but patient does not want to show that spacer outside when he's going outside and so you have to consider the patient's preference and the age, competency and physical ability, and whether whatever the drugs we want to give is available in that preparation or the delivery mode. And also, of course, you have to consider the cost and the environmental impacts. And most important thing is that patient can use it correctly. So follow up, we see what has happened.
Wathsala, just you emphasize the importance of that short-acting antimuscarinic agents, ipraven, should not be used in the long term because of increase their
cardiovascular mortality.
Increase.
Yes.
So that is something that we should emphasize.
Yes, because I think we see so commonly ipratropium given BD regularly for months and months, because it's only one. Sometimes back we had only ipratropium and salbutamol, so that is not the correct management. So because now we have tiotropium fairly freely available, I think we should use tiotropium.
Just another question about the steroid dose. We tend to use in those who in COPD whom steroids are indicated. We tend to use higher dose of steroids like fluticasone. Is it like budesonide preparation might be better in this patients?
Yes, yeah, probably. Lower dose and minimal to control the inflammation.
Because the pneumonia risk is high in this patient.
Patient group. Yes.
So the follow-up of this patient, so he was only on LAMA therapy. So recently he has got exacerbation, that is infective exacerbation, but we couldn't yield any organism from the sputum cultures. Only 2 days history of worsening of SOB, wheezing and chest tightness. So we managed with frequent nebulization and short course of oral steroids. So we did the lung function after the stabilization of the patient. So here we can see that FVC initially 80% predicted, now dropped to 67%. And the FEV1 value still remains around 58% to 56%, but there's marked reduction in the FVC. So the ratio remained normal, but we have to consider about this FVC drop. So we did the bronchodilator reversibility this time, but there's no significant improvement. So we have, so this time also his eosinophil count is more than 300. So we step up these inhalers to LAMA and ICS therapy. That is salmeterol and fluticasone combination with tiotropium. And for long-term care management, so we had to optimize this patient's inhaler techniques and the pharmacoadherence, and considering his cardiovascular risk factors, his lifestyle modification, and this pulmonary rehabilitation, and the vaccination, mainly this pneumococcal and influenza vaccination. And as he's having underlying risk factors, we have to promptly monitor for this lung cancer screening.
Thank you, Kasun. So we'll look at how we are to follow up these patients. So all these patients should be on regular follow-up. So this management cycle is very important. It is important for COPD as well as asthma, similar like. So when you are reviewing, you have to assess the symptoms and the exacerbations, dyspnea. And you have to, as I said earlier, you have to assess the inhaler technique and adherence, and also non-pharmacological approaches, whether they have been adhered, and especially pulmonary rehabilitation and self-management education. And you have to adjust, escalate, or sometimes switch inhalers, or sometimes if it is stable, you can de-escalate. Here, of course, this patient was getting more symptomatic. So now we are more and more interested regarding this treatable traits. So in COPD, the gold guideline, they focus on 2 treatable traits, that is dyspnea predominant and exacerbation predominant traits. That is how they say it. And this patient has dyspnea predominant. So you can say if it's on individual long-acting agent, you can combine it. And if still on combination therapy, you can try to, still symptomatic, you can try switching the inhaler device or the molecules. And also, as I said, you have to escalate the non-pharmacological treatment. And this new drug you can consider adding, of course we don't have it, enicepentine, and also you can consider regarding other causes of dyspnea. Then exacerbation predominant one, when you are started on initial treatment, on review, if the patient is having more exacerbations, either on LAMA or LABA, then you consider the blood eosinophil count. If it is less than 300, you just give the LAMA-LABA combination. If it is more than 300, you can consider the triple combination. And still, if they are not settling, you can consider these agents like roflumilast and also azithromycin, preferentially that is in former smokers, and also dupilumab with a monoclonal antibody. So biologic, yes, especially chronic bronchitis predominant one. So a few words regarding the newer drugs. So we have roflumilast. This is a phosphodiesterase 4 inhibitor. So it is mainly anti-inflammation. It doesn't have a bronchodilator property. The newer one, enicepentine, is a phosphodiesterase 3 and 4 inhibitor, which has combined effects, both bronchodilator and anti-inflammatory. So it is significantly improve the lung function and the dyspnea shown to, and also maybe reduce the exacerbation rate also. Then biologics, you have dupilumab. It's a monoclonal antibody. It blocks interleukin 4 and interleukin 13. So it has shown to be good when you are using in there is 2 large randomized trials, chronic. So they had fever exacerbations and better lung health. when they are on dupilumab, but the guidelines recommend, but studies are going on. So I told this is not a curable disease, and reducing mortality is difficult in COPD. So what are the things that have shown to that be effective to reduce the mortality? So LAMA ICS combination has been shown to reduce the mortality in symptomatic people with history of frequent and or severe exacerbation. And the other ones proven to be effective are, of course, smoking cessation, pulmonary rehabilitation, long-term oxygen therapy, NIV, and lung volume reduction surgery in the certain category of patients if they are indicated. I think we'll be discussing about them in a little bit. So adverse events you have to know if you are using drugs. Antimuscarinics, of course, you have dryness of mouth and small increase in cardiovascular events in epitropium, and sometimes can precipitate glaucoma because of direct contact. ICS, of course, I think all of you know. Then azithromycin increase the incidence of bacterial resistance, prolonged QT interval, and impaired hearing test and mycobacterial infection. And of course, methylxanthines, although useful, has quite a bit narrow therapeutic window, and so there are side effects. So, few words about non-pharmacological interventions. We'll be discussing them in a bit. Reduce the risk factors. So, smoking cessation or whatever the exposure to the risk factor should be stopped, and also vaccination. Whatever the biomass exposures, you can promote non-polluting cooking stoves and so similar interventions, efficient ventilation, and so on. Then, how to optimize the function? You have to encourage in all the patient to regular exercise and physical activity, and provide education and GP follow-up plan. You have to treat the comorbidities. This paper commonly has cardiovascular disease, anxiety, depression, and lung cancer and osteoporosis. So you have to address those issues. And you have to refer symptomatic patient for pulmonary rehab and initiate advanced care planning, and also manage advanced lung disease as we discussed with domiciliary oxygen and so on. We'll be discussing them further. So I don't think this is coming up very well, but this is the Australian guidelines. It's a little bit different. So it gives an idea when to start which non-pharmacological intervention. So all groups of patients, whatever the severity, you have to reduce the risk factors, optimize the function with the encouraging regular physical exercise and all, and optimize treatment of comorbidities, and if symptomatic SOBs there, refer for pulmonary rehab. More advanced patients like moderate and so on, you can initiate advanced care planning, and final stages, you have to, of course, arrange domiciliary oxygen therapy, NIV, and all the other interventions, and sometimes refer for, we have lung volume reduction surgery and different either surgical or bronchoscopically. So we can refer some of these patients, but because of the interest of time, we'll move to the rest of it. So I will... Yeah.
Any comments from the audience or any questions? So at the moment, what we have, if we have a patient who is a frequent exacerbator, the pathways you said, both the emphysema predominant phenotype, we would consider azithromycin in these patients, but you have to exclude mycobacterial disease, right? And in the eosinophilic predominant, goblet cell predominant chronic bronchitis types, the options are roflumilast, which is an oral tablet, and ensifenterine, that's PD3, which is a nebulized drug, not available yet. Yes, and dopilumab, mostly eosinophilic types with goblet cell function, chronic bronchitis, that phenotype.
That group of patients with eosinophilia. But the head-to-head studies are not there with whether this is with that. So we need more studies, I think.
Yeah. So I think, as you said, other strategies, and Dr. Kanthi Nanayakkara, vaccinologist, will speak about the role vaccines play in our patients.
Good afternoon. Thank you, Neranjan, for inviting me. A bit of an odd one out here, I think, in this forum. But I was happy to talk a bit about a neglected area, the vaccines which should be given for these patients of yours. So when you take patients with chronic lung diseases, commonly things like asthma, chronic pulmonary dysplasia, COPD, and cystic fibrosis, there's a higher chance of developing complications. I mean, this is something that all of you all know, bread and butter for you all, following recurrent respiratory infections like influenza and pneumococcal infection. These are the most two important infections which will give exacerbations to your patients. Smoking predisposes for severe pulmonary disease and also pneumococcal infections. Some of the guidelines talk about varicella infection also could cause complications like transient worsening of lung functions, especially in patients with cystic fibrosis. So COPD exacerbations is, I think they say it's one of the leading causes, the third leading cause of death worldwide. And at least 70% of exacerbations are associated with respiratory infections. So quite a percentage of exacerbations are linked to infections, and of which more than 30% are infections with respiratory viruses. And very commonly, it could be either viral, bacterial, or commonly combined, like mixed infections are seen. Streptococcus pneumoniae, the commonest, the most important bacterial infection is strep pneumoniae infection, is the leading cause of morbidity and mortality in this group of patients. So prevention of acute exacerbations is one of the key goals in the therapy for these COPD patients. So what are the recommended vaccines for these patients? The most important are the annual seasonal influenza vaccine, which we commonly call as the flu shot. In Sri Lanka, there are a lot of people who even don't know that there's a vaccine for influenza, and there's the flu shot, which we have had in our country for more than 14 years now. So it's sad. A lot of people don't know. A lot of our doctors don't even talk about the flu shot to their elderly patients and patients with comorbidities. Then the pneumococcal vaccine, the SARS-CoV-2 vaccine, all of you all know. And other vaccines include the varicella vaccine for people who have not had chickenpox or who have not taken the varicella vaccine, zoster vaccine, which is not available in Sri Lanka yet. The 2023 Global Initiative for Chronic Lung Disease report recommends the zoster vaccine for these patients. The pertussis vaccine is also recommended by some of the guidelines, and in the near future, the RSV vaccine also will come to play, because respiratory syncytial virus is also a known cause of acute exacerbations for these COPD patients, and there is now a candidate vaccine which has been recommended or authorized to be used for adults, RSV pre-F3, but there are not very many manufacturers yet for these vaccines. But despite studies and national guidelines demonstrating that vaccinations are beneficial in the COPD patients, the worldwide vaccination coverage remains low. So not only in our country, this is supposed to be a worldwide problem. So to talk a bit about the seasonal influenza vaccine, each year the manufacturers of influenza vaccine produces two vaccines. I hope maybe you all know about this, the Southern Hemisphere and the Northern Hemisphere vaccine. And there's the live attenuated as well as the inactivated vaccines. And inactivated vaccines are the only vaccines which are recommended for these patients with chronic problems and as well as the elderly. So there's a standard antigen vaccine and higher potency vaccines. Now, the commonly available influenza vaccine has a standard dose of antigen, which is about 15 micrograms of each antigen. And usually they are made as trivalent or quadrivalent or tetravalent vaccines. The trivalent vaccine has 2 influenza A strains and 1 influenza B, and the 2 influenza A strains being the pandemic influenza strain H1N1 and an influenza H3N2 strain, and 1 influenza B strain in the trivalent. So 2 influenza A and 1 B, and this influenza B is always from there are 2 lineages of influenza B, which is called Victoria lineage and Yamagata lineage, and in the trivalent it is always influenza B coming from the Victoria lineage. And I don't know whether you heard, the WHO this year gave a recommendation to all the manufacturers, because manufacturers were moving from trivalent to quadrivalent vaccines because it is more like, good for them because the cost is slightly more also. But it is not doing anything much because the world has not seen Yamagata strain of influenza B for over 10 years now. So, because the quadrivalent vaccine has the same 2 influenza A strains and 2 influenza B strains, one from the same as you get in the trivalent, and the second strain is Yamagata lineage. So now 2024-2025 Northern Hemisphere vaccine and 2025 Southern Hemisphere vaccine is only going to be trivalent. The WHO has said not to manufacture a quadrivalent for next year because there is no advantage. Okay, so in Sri Lanka, what do we have? We do have both Southern and Northern Hemisphere influenza vaccine from 2023. So up to that point, we only had the Southern Hemisphere vaccine. Why was it? Why was only the Southern Hemisphere used in Sri Lanka, or registered and marketed in our country? Because our virus strains, because every year the viruses are being put to the flu net from all the countries, and when you map it, our virus strains commonly match with the ones which are more towards Australia and the southern part of Sri Lanka being 5 degrees, I think, north from the equator, but it's mainly like the Southern Hemisphere type. But in the temperate countries, all of you all know, flu is usually seen during winter. But in countries like tropical, subtropical, it is like through the year. But we see like 2 small peaks coming, one somewhere from about March, April, May, and another peak from about November, December, January. So they coincide with our festive seasons, our Urudu visits and all that during March, April, May, and end of the year during Christmas shopping and a lot of activity going on, and the rains also, monsoon rains. Okay. And WHO recommends now for tropical and subtropical countries to use whatever the vaccine which is available at the time the patient comes for a flu vaccine. Okay, so we don't have to wait for one. But I mean, in Sri Lanka, we always feel if you are living in our country, it's better for people to be with the Southern Hemisphere because that matches better. Okay. So how do you give the flu vaccine? A single, like for older people, even for the first time, you just go for 1 single IM dose followed with an annual booster. You don't have to take both Southern and the Northern Hemisphere every 6 months. No, you don't have to do that. So you can stick on with one and go on taking a booster annually. But the standard dose vaccine, the vaccine which has 15 micrograms of each antigen, seems to be less immunogenic in the elderly and patients with chronic diseases. But in Sri Lanka, at the moment, we only have this standard dose inactivated surface antigen influenza vaccine. But still, it is doing some good to patients. Okay? So, are there any better vaccines for influenza for this group of patients? Yes. There are things like enhanced dose influenza vaccine, which is 4 times more potent. That is 60 micrograms of influenza antigen from each strain is there. So, it is like 15 into 4 times more potent vaccines are available. A recombinant influenza vaccine, what we have in our country is the standard influenza vaccine, which is the embryonated egg-based and inactivated split virion or surface antigen vaccine. At the moment, what we have is the surface antigen influenza vaccine. So this is a recombinant influenza vaccine from cell culture base, which is more immunogenic for these patients. And adjuvanted vaccines, adjuvants are things which are put together with vaccines to make it more immunogenic. Like you have alum in your DTP tetanus vaccines, to make it more immunogenic. Likewise, the standard influenza vaccine together with MF59, that is another adjuvant. So adjuvanted vaccines are also available. So maybe in the future, we may get these vaccines to our country. Okay, the next important vaccine for these people is the pneumococcal vaccine. There are two types of pneumococcal vaccine because pneumococcal vaccine is a polysaccharide vaccine. Okay, so polysaccharides are less immunogenic when you compare with proteins. When you give a pneumococcal vaccine, how a person responds is less, like lower. That is why the polysaccharide vaccines cannot be given to babies under the age of 2 years. You have to give a conjugated. A conjugation is like with a protein that the polysaccharide is being combined where it is more immunogenic. Okay, so we call them the PCV or the pneumococcal conjugate vaccine. There are different manufacturers make 10-valent, 13, 15 and now latest 20-valent pneumococcal conjugate vaccines are available, but of which in Sri Lanka we still only have the 10-valent pneumococcal conjugate vaccine. Then there's a pneumococcal polysaccharide vaccine, which is 23-valent. Worldwide, what is available is a PPSV 23. And at the moment in Sri Lanka, after a long time, now we have the pneumococcal polysaccharide vaccine. So this is for your information. We are finding it difficult to push this vaccine. It is available now in the government sector. And when people, chronic illnesses, when they go to the clinic, the easiest thing for our immunization clinic, I mean, it is a problem, and I tell people, please call me from the hospital, and then I speak to the sister there, and then you have to contact the pharmacist. It is there. And the awareness is not there. Okay? So it's sad, like after having it also, it was so difficult to, during the times like we are in, with the financial difficulties, with difficulties, we got the vaccine to the country, and it is not available in the private market at the moment. It's only, the PPSV 23 is only available in your hospitals, government hospitals. For patients with chronic lung problems, what is the recommendation? The recommendation is first to go for a dose of conjugated vaccine. The world says, most of the studies say 15 or 13-valent pneumococcal conjugate vaccine to be followed with a dose of PPSV 23 after 8 weeks. That gives the best response for these patients. But there are not enough studies to show that even the PCV10 should work. There are some amount of cross immunity. So in Sri Lanka, what we recommend is to go for what we have at the moment. A dose of PCV, follow in 8 weeks with a dose of PPSV 23. And if a person is less than 65 years, you are supposed to give another booster dose when the patient reaches 65 years, if there's at least 5 years passing the dose of PPSV 23 that you have given the patient. Okay, so if it is like a 63-year-old person, you give the PCV and follow with the PPSV 23, you wait for 5 years and go for one booster dose. If you start this when the patient has passed 65 years, you don't have to go for boosters again and again, because there is supposed to be a bit of a negative impact by giving every 5 years a dose of PPSV 23 that blunts your cell-mediated response. So you don't have to give repeat boosters. So it's either maybe one dose of PPSV 23 following PCV, or maybe another second dose after 5 years if the patient was given the first dose before the age of 65 years. I hope I am clear. So what are the take-home points? Prevention of exacerbations with immunization is a cornerstone prophylactic measure for COPD patients. And immunization is at suboptimal level worldwide. Okay, worldwide the use is less. The advanced, the affluent world, I think they are using it better than the countries like ours, but worldwide they say the use is suboptimal. So what are the most important recommended vaccines? The yearly influenza vaccine is the most important, and if you have highly immunogenic products which are better, but if you don't have them, even the standard dose influenza vaccine is doing good for these patients. Pneumococcal vaccine, that is the PCV followed with the PPSV 23. And now there are studies to show if you give PCV 20, you don't have to follow them with PPSV 23. But there are only one manufacturer, as far as I know, who produces PCV 20, so it's not available in most of the countries. So one day when a PCV 20 is available, you can wait even without going for a PPSV 23 booster. Then SARS-CoV-2, the recommendation is, to give the primary course of immunization, and all these patients, the elderly and patients with chronic illnesses, to follow them up with the most recent kind of mRNA vaccines every 6 months to 1 year. And my sister at the moment is down with COVID in Australia. She has got her 8th booster dose. Can you believe it? Because she has some chronic problems, so she is on immunosuppressants. She's being given a shot every 6 months to 1 year. But with that, she's at the moment down with COVID. Okay, so that is the bivalent, the new COVID vaccine with Wuhan and the Omicron strain together. That is the recommended vaccine at the moment for these patients as boosters. Then 2 doses of recombinant zoster vaccine. There are 2 types of zoster vaccine, the live attenuated zoster and the recombinant vaccine. For this group of COPD patients, it is recommended to go for the recombinant zoster vaccine with a gap of 3 months to 6 months, which is not available in Sri Lanka yet. And the most important take home is awareness regarding immunization should be improved, both in physicians as well as patients. Thank you. Happy to answer any questions if you have.
Yes, thank you, Dr. Nanayakkara, for a very informative and very extremely valuable information that we have provided. One of the most important and most valuable information and clarifications of several points that we are grappling with. One is regarding the influenza vaccine. The manufacturers promote this, the tetravalent one and the Yamagata strain. It's heartening to know that we can ignore that.
At the moment, for the 2025 seasons, we are not
Yamagata is not a problem.
They are not going to make quadrivalent.
They are not going to make. Yes. The other issue being that the northern hemisphere and southern hemisphere. So when my son went to Australia, they said he has to take the southern hemisphere. Yes. You are in Sri Lanka, you would have taken the northern hemisphere. But it is the southern hemisphere that we take.
Yes, in Sri Lanka up to 2023, we only had southern hemisphere.
Yeah, you clarified that, saying that though we are north of the equator, what we have is sometimes this need this thing arises when parents are going to northern countries with the elderly grandparents looking after grandchildren on their summer holidays.
So actually now what we promote is depending on where you are traveling. Now there are a lot of our parents young people have gone abroad. So part of the family is here in Sri Lanka, part is either in Australia side or part in US, UK or somewhere. So parents who are visiting their children in the northern hemisphere, let them be on the northern hemisphere annually while being in Sri Lanka also. Because now both are recommended for the tropical and the subtropical countries. And if you are mainly visiting towards Australia side, take the southern hemisphere vaccine annually.
The other issue is you mentioned 2 seasonal peaks, one in March, April, and the other November. So what is the best time if you are giving a single vaccine, a single annual booster of influenza, what is the best time of the year to give?
There is no best time as such, because like in the temperate countries, they give it about 3-4 months before the winter season to prepare the people for the winter. But Sri Lanka, it is through the year. So in Sri Lanka, normally the southern hemisphere becomes available by about beginning of April or mid-April, March, April, latter part of March or April. So a lot of people start taking it from about April, May when the vaccines come, because people have got used to not having the northern hemisphere those days, only the southern was there. And what happened is when you have only one seasonal flu, by about September, October, sometimes the stock of vaccines finishes.
But
now it will not happen. Neranjan, because it will be available because we are having both hemisphere vaccines, so it will be available through the year.
So March, April is the best, and they need not have a second vaccine unless they are traveling.
Yes. I mean, whatever the time, you get to, you advise a person
when it becomes
to
available.
take it. take it.
Take it. Okay. Some people, another concern is some people wait. Now, if you have taken the vaccine last year in June,
Yes.
they say there's
You don't
time
have to
till-
wait for
yes,
one whole year.
one whole year. You don't
You
have to
can,
wait.
like anything after 6 months, you can get the booster.
Yes.
So, I mean, you're not supposed to, like, you're not like pushed to take every 6 months. But if you have taken, we'll say, I have taken my southern hemisphere. After about 8 months, I'm planning to go to Australia during the winter time to Australia. I better take the southern hemisphere. Or if I'm going to the US, I can take the northern hemisphere if you have passed about 6 months from your previous shot.
Okay. Okay. And thank you again for the pneumococcal vaccine and clarification that you made, because earlier we used to ask them to take
Every 5 years. Yeah.
every 5
Actually, we
years.
see like a lot of patients coming and asking for 5-year boosters. So you don't have to give it like that. Pertussis vaccine, what they say is, pertussis vaccine doesn't come keep as a separate pertussis. It is a combination which is there with adult diphtheria, tetanus, and the acellular pertussis, what we call the Tdap. Once every 10 years to take a Tdap booster, that's the recommendation where you just maintain your antibodies towards tetanus, diphtheria, and pertussis, all three.
Another pneumococcal vaccine?
In the sense like we got this year because last year we got a donation of 7,000 doses and we just couldn't push the vaccines. About 3,000 doses went waste. This year, because we bought it this year, the tender was like, we thought we will buy about 4,000 doses for this year, and we have already got 2,000, and we are planning to get the next 2,000 in 6 months' time. So please, your patients are more than welcome to go to the hospitals, and you will have to push, because sometimes I get very annoyed with.
There should be a communication system.
Yes.
Initially, because last year
Yes.
we were informed like only 6 months prior to the expiry date. So that we couldn't
Because that is the
distribute
MSD, when they suddenly realize there's a stock of vaccine which is getting closer
Yeah,
to
we
expiry,
got
then they will
That's what
talk
they did.
about
They
it.
said there's a donation and then.
Yes.
Yeah.
But we didn't know that we had purchased and it's available.
Yes.
We didn't know.
And
didn't know.
another, I think, a bit of a problem we have, the PPSV 23 from Merck Sharp and Dome is they are not supplying Sri Lanka because our market is so small, it is not worth for them to send vaccines. So we managed to get a vaccine from China. The problem is the label and everything is in Chinese, and they have given us a separate leaflet in English. But it's a good manufacturer. But only thing is, people were a bit worried when it is all in Chinese. But now people can always Google Translate and see what this is. Only the Ilakkama 23 is there that we can read. Everything here is in Chinese.
Is para-influenza is also a concern in our countries. We had few cases last year.
Yeah, maybe, but there's no vaccine for para-influenza, and the influenza vaccine will not give a cross immunity.
Are
for
we
para-
not diagnosing or like?
I think maybe we are not diagnosed.
You have the facilities of rapid multiplex PCR here in MR?
For respiratory, yes.
Yes.
For
RSV
respiratory,
as well.
we do have like few of the respiratory. There's a combined respiratory panel which have influenza A, B, RSV, and
And the para-influenza.
and I think para is also in that.
So one final question about the respiratory syncytial virus vaccine. Is it also annual vaccine? And is
That Amita, to be frank, I'm also not sure because it is not yet.
there's a lot of talk about patients with cardiovascular comorbidities that it is good.
Yes, so it is something for the future. So I don't know what the guideline is going to be like for RSV vaccines.
Thank you then. Thank you everyone.
Thank you very much.
Thank you very much. That brings us to the end of the first session. Thank you very much for all our panelists for a very comprehensive and engaging discussion. Ladies and gentlemen, in the interest of time, we'd like to move on to the second session of the day. I'd now like to invite the panelists of the second session, Dr. Kanthi Nanayakkara, Senior Consultant Respiratory Physician, and Dr. Dilesha Wadasinghe, Consultant Respiratory Physician and Senior Lecturer of the Faculty of Medicine, University of Kelaniya, Dr. Ruwanthi Jayasekera, Consultant Respiratory Physician and a Senior Lecturer attached to the Faculty of Medicine, University of Moratuwa, to take your positions on stage. And I'd like to hand over the session to Dr. Dilesha Wadasinghe, Senior Registrar in Respiratory Medicine. Over to you.
Okay, good afternoon everyone. So it is pleasure to welcome you all to a session of changing landscape of COPD meeting. Where we are discussing about a critical topic, exacerbation of COPD. So, changing landscape of COPD session 2, exacerbation of COPD. So, this is our case scenario. Mr. A, who is a diagnosed patient of COPD for 10 years on regular clinic follow-up with good inhaler technique and the adherence, and he's a 64-year-old and he was an ex-smoker with a pack year of 10 and his abstinence for about 5 years. And he presented to us with insidious onset, progressive shortness of breath with MMRC grade 3 product, and also he reported that he is having productive cough for 10-day duration. And there was a history of fever for 2 days, which was intermittent and responding to antibiotics, but there is no history of loss of appetite, loss of weight, and there is no contact history of tuberculosis or past history of tuberculosis. Also, he denies neither history of ischemic type chest pain or no features of heart failure. And his last hospital admission due to COPD exacerbation was 1 month back, and his past medical history was significant for 6 hospital admissions per year due to COPD exacerbation, out of which 3 were complicated with type 2 respiratory failure. Examination findings on admission were his airway was patent and breathing was dyspneic with respiratory rate 30 per minute and using accessory muscles. SpO2 82% on air, bilateral scattered bronchi over lung fields and coarse crepitation over left side lower zone. Pulse rate was 110 beats per minute, blood pressure was 126/84. And he was conscious, rational, and GCS was 15 out of 15, and pupils bilaterally equally reacted to light. And he was febrile at the moment. Temperature was 100.6 Celsius and CBS 223 and BMI was 27. So ABG on admission showed there was pH 7.28 and PCO2 94, PO2 61 and lactate level was 0.8, bicarbonate was 41.2 and SpO2 85%. So he was having a type 2 respiratory failure with respiratory acidosis. So I would like to invite Dilesha Madam before going ahead with the investigation to talk about diagnosis and severity assessment of the COPD.
Yes, Dilesha. Now, this is a patient who has come with recurrent exacerbations, and how would you sort of assess him and progress from there onwards?
Yes. Now, so first of all, let's see what is an exacerbation. So we have had a nice panel discussion on what the stable COPD patient is and how. So the exacerbation definition has been changed in GOLD 2023 onwards, and where they have included, the previous classification was there is increased symptoms of COPD, no duration, no what symptoms are increased. But now here they have clearly said increased dyspnea, increased cough, sputum production, and it should be less than, for worsening in less than 14 days, and accompanied by physical signs, tachypnea, tachycardic, and also they have given a causative cause in the definition, whether it's infection, pollution, or whether it is an insult to the airways. And having said that, now our patient will not come by telling I have COPD, and they will not come and tell you the symptoms. So there will be a group of patients who have not been diagnosed with COPD. There will be a chronic smoker coming with the breathlessness, increased cough and purulent sputum. So is it only COPD? But so there could be other symptoms or other differentials which we need to think about. And what are they? So pneumonia is one of the very common causes, pulmonary embolism. So we know as trainees, we have been told if it is a non-exacerbation, a non-infective exacerbation of disease, lung disease, always think about pulmonary embolism, whether it's a cardiac cause such as heart failure, myocardial infarction, and arrhythmia, or whether there is an underlying pneumothorax as well. So we need to think about these in our investigations as well. Now, the assessment just from the basics, right? So we start with respiratory rate, the breath sounds, you assess the patient's oxygenation, then you consider the basic investigations with full blood counts, CRP. Procalcitonin is here, but we don't have enough evidence to suggest that procalcitonin is, it has not come into the guidelines, but we can use it in certain instances to assess whether our patient is having an infection or not. And then kidney liver functions, a chest x-ray is very important, blood gas is very important, and also if it is infective exacerbation like in our patient with a history of fever, we need to think about throat swabs, sputum cultures as well. And now the classification of severity. Previously, the classification of severity was retrospective. After you discharge, whether you just gave bronchodilators, then it was mild. If you gave bronchodilators plus steroid and antibiotics, then it was a moderate exacerbation. And if you needed non-invasive ventilation, then we classified it as severe. But here, now the newer guidelines has given certain criteria and the dyspnea using a visual analog scale, respiratory rate, your heart rate, your resting saturations, your CRP level, and if the blood gas is available, and we can classify whether it's mild, moderate, or severe. So difference, mild, all the parameters will be within normal, saturation will be more than 92%, and CRP will be normal as well. In moderate, you can have either three of the 5 factors listed here, plus your blood gas will show a respiratory failure, but you will not have acidosis. If you have acidosis, then you go to the severe category. Right. So in our patient, so these are exactly the same things what I told you. And in our patient, respiratory rate was 30, 110 pulse rate, saturation was 82 on room air, and the CRP was high, acidosis with increased carbon dioxide levels. So it's severe, not life-threatening. Why I say is because according to what we call life-threatening, the mental status of this patient was quite normal, and the pH was above 7.25. So someone can tell that it's impending life-threatening, but or it is a not life-threatening disease in here. So when are we going to do a blood gas? So there was a blood gas shown as well. So immediately after admission, so this is for the audience. Are we going to option A or option B? Immediately after admission or 1 hour after optimal management? Hands up for immediately after admission? Yeah, 1 hour after optimal management? Yeah. So it's 1 hour. So when the patient comes in, right? Securing the airway, giving a bit of oxygen, nebulizing the patient, and if needed, steroids are the initial management which you'll have to start with, right? So controlled oxygen, and then only you go for a arterial blood gas assessment, right? And that is what was done at Wathsala on our patient as well.
How did you proceed from there onwards?
So now the investigations are the next step what we would have performed. So I would like to let know the investigations of these patients. So with the chest x-ray and then the routine bloods, ECG as well.
So this is the chest x-ray. It showed that there is a flattened diaphragm and hyperinflated lung fields, but at the moment patient didn't have any consolidation or pleural effusion. ECG just shows that sinus tachycardia, there was no ischemic changes. imaging that was previously was done, and it only shows bilateral emphysematous lung fields and no features of ILD. And to the echo showed there is good left ventricular dysfunction, but there is only mild pulmonary hypertension. Other serum investigation on the admission, full blood count shows WBC 16,000 with the neutrophilic predominant, E count was 200. Hemoglobin was 13 and platelet was 345, CRP 146, which gives evidence of infection, and infective screening was negative with the sputum pyrogenic culture, and AFB sputum and gene expert all are negative. And troponin I was negative. Anyway, we excluded by doing excluded ischemic heart disease, even though there are no ischemic acute ischemic changes on the ECG. So our treatment goals was minimize the negative impact of the current exacerbation and prevent the development of subsequent events. So, Madam, we discuss about the management part.
Okay, now deliberately I asked her not to put the E count here, because the reason is most of us as people working in medical wards, we tend to neglect the eosinophil count. But it is very important because that is now, as we saw in the previous lectures as well, in COPD, whether to give steroids or not is based on your E count in stable COPD. There are studies showing that it's similar in the acute exacerbation as well. I will tell you why that is in my later slides. So there is evidence that you offer the short steroid course, the systemic steroid course for if the E count is more than 200 or 100, but not for everybody. But it has not come into guidelines yet because we don't have a lot of evidence to put it into guidelines, but the researchers are ongoing. Right, so treatment goals in acute, as we told previously, you have an acute exacerbation, your prognosis gets worse, your lung functions goes down, right? So we need to minimize the negative impact from the current exacerbation on your lung functions, your prognosis, and you'll have to prevent development of subsequent events as well. So in this patient, so what we did was these are the stepwise what we do, right? So you can do the initial investigations, you give supplementary oxygen, controlled oxygen, and then you add on bronchodilators, you consider corticosteroids, antibiotics, and non-invasive. So let's talk one by one. So oxygen, Venturi mask is better option than the nasal prongs. Aim for saturation 88 to 92 in a previously known type 2 patient. But if there is no previous type 2 respiratory failure, you can aim for a higher, about 94% of saturation. Right. So, and then this is the evidence. We have evidence C for short-acting bronchodilators, and we have evidence A for systemic corticosteroids to improve your lung functions, your oxygenations, and shorten the recovery time and duration of hospital. But this does not show a survival benefit, right? So this is another slide, whether oral or IV prednisolone steroids. There is no difference from oral to IV. The reduced trial shows that you don't need to give a longer course, just 5 days is more than enough. And is it an inhaler or a nebulizer? There is somewhat favoration for the nebulizer at initially, but once your patient is stable, you can switch to the inhaler because it will give a more potent dose of the medication. Right. So there is a lot of side effects with the steroids, what we know, right? A huge acute and long-term side effects. But we know that it is for the long-term prednisolone only. That's what we think. But then this systematic review, right, shows very clearly that a short duration of steroids has increased sepsis, respiratory, musculoskeletal conditions, thromboembolism, fractures, right? So we need to think very carefully when we are selecting our patient, putting our patient on a short steroid course, right? So even a short steroid course can give rise to these complications, right? And then antibiotics. Not everybody needs antibiotics. Commonest cause is a viral exacerbation. So your patient should have at least 2 out of these or 3 out of these cardinal symptoms. Dyspnea, sputum volume should increase, and your sputum purulence should increase. So very important, the sputum purulence should increase. Or if they need mechanical ventilation, invasive or non-invasive, right, then we can consider starting on antibiotics. So everybody does not need antibiotics. Then NIV, very solid evidence for NIV, better than high flow nasal therapy. And NIV, we give it for respiratory acidosis with a pH of less than 7.35 and a PCO2 of more than 6, severe dyspnea and persistent hypoxemia. So this is the same thing what I told you about the indications, and there is ample evidence that showing that it shortens the admission length, less mortality, less morbidity, and need for intubation. Right. So this shows the evidence in reducing treatment failure, mortality, intubation, and complications. So this is another guideline which showed 6.5, but the gold guideline says if your PCO2 is more than 6.5, you can go for NIV. Remember, NIV is not for hypercapnic who are not acidotic. Right? This is in the ERS guidelines. So you don't need to give NIV. Your NIV is not recommended for non-acidotic type 2 respiratory failure patients in an acute exacerbation. Right. So when you are putting on NIV, you should know when not to put NIV before you start on NIV. So you should know the absolute contraindications. You should know the relative contraindications. And another concept which you get wrong is, when I tell NIV, it is bi-level ventilation. It is not CPAP, right? Even in private sector, even in hospitals, people tell me, patient was in respiratory distress, we put on CPAP, pressure support is this much. I asked, when do we put a pressure support for CPAP, right? So CPAP is only for type 1 respiratory failure, especially pulmonary edema. Right? And this is bi-level ventilation. If you need to wash out carbon dioxide, you need to put them on bi-level ventilation, where there are 2 levels for the expiration and the inspiratory pressures. Right? Okay. And you should know when to put them in ICU as well. Right? So NIV setup, we can set the pressures, how to select the pressures. It all depends on your patient's condition. If your patient is obese, they may have, which Ruwanthi will tell you about, obesity-associated disorders such as OSA, OHS, right? So if they are obese, we go for a higher EPAP because we need to splint the airway and keep it open. And if it is not, then a 4 or 5 EPAP is more than enough with a IPAP of 10 to 15. We increase this depending on the patient's saturation, to look at the patient's work of breathing reduction, and also to maintain a good alveolar ventilation. So those are the aims. So you start from this, and you don't need to keep on this, but you can titrate it to achieve a good alveolar ventilation and the saturation targets. Then wait for 1 hour and repeat your blood gas. Right. So what is the investigation you should do before starting on NIV? Very importantly, it's the chest x-ray, because you should not put a patient on NIV with an undrained or missed pneumothorax. So do a chest x-ray every time before you put your patient on a non-invasive ventilator, because clinically you might miss a pneumothorax, a very small pneumothorax, but it will be worse. There will be worsening if you miss that in pneumothorax, right? So mask interface is very important. There are various types of masks. In the acute setting, recommended is the oronasal mask, because your patient, when you see next time you go to the ward, take a look at it, they will be mouth breathers. Right? When you are in respiratory distress. So an oronasal mask is what is recommended. So select the appropriate size. I have seen patients with the nasal mask larger than or smaller than, which is not effective. This mask is the most important in non-invasive ventilation, right? And you need to look for this bar if you have a ResMed Stella, right? So the leak what is your respiratory rate, your inspiratory time, your tidal volume. So tidal volume and your leak is the most important, and see whether your respiratory rate is coming down when you're doing the monitoring the patient. And also after 1 hour, right, in any change of your settings, wait for an hour, wait the patient till the patient is stable, and repeat and see whether you are heading in the correct direction. Right? Whether your carbon dioxide is normalizing, your acidosis is normalizing, patient's respiratory rate and the work of breathing, always you can monitor continuously. Right. These are some 4 things which I usually ask in the ward round from a patient who is on NIV, because there is side effects or adverse effects of this mask. If it's too tight, you can get wounds on your nasal bridge. So is it too tight? Does the machine deliver adequate breaths when you are trying to inhale? When you are trying to exhale, does the machine support your exhalation, or is it still blowing air at you? That means your inspiratory time in the machine is too high. Right? So those are some things what we can ask the patient, right? And does the machine, when you're trying to exhale, so that is what we ask. So the flow rate and all of these questions you can ask to know that the patient is comfortable, right? And you should know when you should escalate to invasive mechanical ventilation. Invasive mechanical ventilation is also recommended for some of our patient categories where they have not much comorbidities, previous activities are quite good. Right. I think we will discuss this probably later. How important is an exacerbation history over the past year of assessment, because this will be dealt in our next presentation, right? Dr. Ravini will be talking about this. So what is the importance of the exacerbation history? Because we have a home NIV service as well. One last slide I want to tell you all about is, so this one. So after an acute exacerbation, 2/3 readmits within the next year. After a severe exacerbation, 1/3 would die. So preventing the next exacerbation is very, very important. So all what you learned in the previous lecture, previous symposium, vaccination, pulmonary rehabilitation, NIV when indicated, LTOT when indicated, is very important in preventing the next exacerbation, and not to forget the nutrition of your patient. Right. Okay. And let's just quickly ask what happened to the
management of this patient?
Yes,
your patient?
The management of the patient, she will be just telling us briefly.
So after excluding the pneumothorax, we started on him in IV with 4 liters per minute with supplementary oxygen, and targeting the oxygen saturation between 88 to 92, as there is evidence of type 2 respiratory failure and respiratory acidosis. And BiPAP with the IPAP of 18 and EPAP of 5, and backup rate was 16 per minute. And we also nebulized with salbutamol and ipratropium and IV ceftriaxone 1 gram TDS, and short course of oral corticosteroids, and triple inhaler therapy, and also hydration. So after the initial management, repeat ABG after 1 hour of NIV, it shows there is pH 7.4, which was previously it was 7.28, and PCO2 80.6, and PO2 73.5, and lactate level 0.9, and bicarbonate 49.4, and SpO2 90%. So you can see there is a reduction of PCO2 from 94 to 80, and improvement of the oxygenation. So we continued our management, and the patient was managed as infective precipitant severe exacerbation of COPD, and NIV settings were adjusted according to the ABG findings. So on admission, so this is a summarized chart on admission, pH and PCO2 and the O2, and day 2, again we changed our BiPAP settings because still there is high retention of CO2, therefore increased the BiPAP settings to 20 to 5 and continued that, and we tailed off the NIV settings with the pressure and also duration. So at discharge, the patient's oxygenation saturation on room air ranged between 89 to 91. Home NIV device was arranged for the patient to ensure the ongoing respiratory support, as there was recurrent exacerbations, more than 3 requiring NIV. And nutritional optimization and vaccination were addressed during the hospital stay, and the patient was discharged with the triple therapy inhalers, oral antibiotics, and follow-up appointments for continued monitoring. Thank you.
Thank you, Dilesha, for that very detailed presentation on an exacerbation. Now, you were talking about steroids in the acute setting, and there were so many drawbacks also that they have highlighted. What is your message to the audience about this using of steroids in the acute exacerbation of COPD?
Yes, sir. So it's very important to identify the correct patient who needs the steroid. So rather than giving it to every patient. So the steroids and the recommended dose is 0.5 milligrams per kilogram body weight. The guideline says 40 milligrams per kilogram because probably maybe they are thinking about the patients in the European setup. But then the recommended was 0.5, so which we can use. And eosinophil count guided treatment would be very promising in the future, so we can prevent using some of the unnecessary steroids as when we are using in the exacerbation.
Because as clinicians, sometimes when you get a very bad patient and perhaps your eosinophil count is not more than 300, what is your situation then? Would you refrain from using steroids or would you continue giving the steroid?
So at the present moment, because some of our patients are asthma COPD overlap as well. So in that context, yes. And if the patients clinically, we will definitely judge the patient whether if the patient has a lot of bronchospasms and the patient is having a lot of symptoms where we would think the steroids would be of benefit and not a huge infection burden. And then in that case, of course, I will still put a steroid. But then my target will be, sir, to minimize the number of steroids I use per year. So all the other treatments what we have used will be something what we will think about using, plus the inhaler technique of our patient. Yes, the pheno will have a place, but not in. Yes, sir.
Energy savings and CO2 washout strategies. We see frequently that the patient uses a very high backup rate. This patient currently is 60 and is slow. What are the thoughts on now? We are feeding the Stera machine, manipulating the PI and the PI max to get a RE ratio as opposed to setting a high backup rate. We see this when we see reference from medical reports that people tend to use a very high backup rate as a CO2 washout strategy. And also in this patient with autopsy, we may have autopsy. The impact of flow is adequate or a little above.
And now that the EPAP, though we start with 4, to maintain your oxygenation, your saturation target, we can go up. So 4, 5 if you are non-obese. If you are obese, then you would need about 6 or 7 of a EPAP. And for the auto-PEEP also to be corrected. And for your first question with the high backup rates, there is a method where we use the increase the backup rate for carbon dioxide washout, but it is not at the initial stage. What we do is we increase the pressure support, but when your patient is not tolerating the pressure support, it's too high, then what we do is the patient's actual respiratory rate will be high. So the backup rate will be increased just a few numbers below the patient's actual respiratory rate. So that the increased respiratory rate where what the machine will support will cause a washout of carbon dioxide which will contribute to it. So you don't want to increase your pressure support gradually to a higher amount when the patient cannot tolerate it. So increasing your backup rate will also help in washing out carbon dioxide plus reducing the need for higher pressure support for the patient. So that we usually do when you are failing, that we increase it and the patient is not tolerating, patient is struggling, then you can increase your backup rate.
Machine, we tend to manipulate the TI min and the TI max, TI ratio of 1:4 or 1:3, rather than.
Yes.
So what is the weaning protocol, best weaning protocol, time weaning or pressure?
So usually we don't, on NIV, we don't do a pressure weaning as such. What we do is a time weaning. So we start weaning off the patient from during the daytime, every 2 hours or 1 hour. So depending on the patient's clinical. So you monitor when the patient is off the NIV. What is the patient's respiratory rate? If the patient's respiratory rate is increasing, work of breathing is increasing, then you don't wait for 2 hours. You would put them back on the NIV. Then that means the patient can't stay for a longer duration of NIV. So then 1 hour, 2 hours, or maybe half an hour, you can start gradually off and on, off and on. If the patient can tolerate 4 hours of NIV without an increase of work of breathing, that means the patient is safe to wean off during the day. And what I usually practice is I keep overnight for a couple of days through a continuous NIV, and then only once the patient is off NIV completely during the day, I stop the patient from NIV.
What is the permissible hypercapnia you would tolerate in such a patient?
There is no actual cutoff for that as such, sir. But if the patient's acidemia is corrected, you don't want to aim for a 45 to 40 carbon dioxide level. So maybe below 50, 55 is all right.
If there are no further questions, I think we will proceed with the next lecture.
So one questions.
Sorry.
Dilesha, just now you said you have to have acidosis to give an IV, but in practical setting, we have these patients in the ward setting sometimes with very dyspneic, but not acidic. There's no acidosis, respiratory acidosis, but CO2 is quite high, 80 and so on. So at that time, what is your advice? Because commonly we sometimes give an IV for sometimes and tail off. So what is the evidence and what is your advice?
There is no evidence for using NIV in the patients who are not acidotic. But now, in practice, sometimes when the work of breathing is very high, just to prevent them from going to a exacerbation of the acidotic respiratory rate, prevent them from going to that, we might use for a shorter duration of NIV. That is not in guidelines, but it is the clinical judgment what we usually do. So there is no clear evidence for that because maybe no one is studying on that, but long term there is no benefit, mortality benefit or morbidity benefit by using it on non-acidotic patients. So that is the reason why it is not in the guidelines. But clinically, if you think that the patient will go into a type 2 respiratory acidotic level, you can use it if you need. So that is basically I will tell it's clinical judgment of the clinicians. But make sure you will not keep that on for long term, right? Because or you will just use it for a few things. And optimization of the rest of the treatment is very important because most of our patients inhaler techniques, I would say, is rubbish. Right? Even though once we teach them, there is research shown in the countries which are having the developed countries also, about after a month, 50% of the inhaler techniques after being taught is again incorrect. So let alone in Sri Lanka, we don't even teach them most of the time. So if you look at it is very important. If you teach the correct inhaler technique, some of these exacerbations can be prevented. Thank you.
Next, I think we will go on to the comorbidities of COPD, which is a very important topic.
Good afternoon. So all this time we have been talking about the respiratory aspect of COPD, but when you look at the COPD as a disease as a whole, and when you look at how it happens or the pathophysiology, you understand that COPD is not just a disease of the lung, but it affects the whole body. So therefore, this topic, the non-respiratory complications and the non-respiratory aspects of the COPD is very important and timely, so that we manage the patient as a whole. So the non-respiratory complications, which I will discuss, I will touch on the important aspects, will contribute to the morbidity and mortality of the patients as much as or more than the respiratory component of the patient with COPD. And this is main, and when you look at it if you just put in one sentence, the non-respiratory and the respiratory complications are a result of inflammation, oxidative stress, and metabolic imbalances. So there are several important aspects. Of course, there are about more than 20 non-respiratory complications of COPD, but highlighting a few: cardiovascular disease and COPD, metabolic syndrome and diabetes, skeletal muscle dysfunction, osteoporosis, and psychological disorders. So COPD is strongly linked to ischemic heart disease, heart failure, and arrhythmias because of systemic inflammation, and COPD is associated with insulin resistance and features of metabolic syndrome, associated with osteopenia, and let's look at how it happens. So the underlying pathophysiology for non-respiratory complications are the same pathophysiological mechanism for the chronic inflammation and COPD as well. It involves both the innate and adaptive immunity, and this when the immune system is activated, it results in both the emphysema with parenchymal involvement and chronic bronchitis, which predominantly affects the small airways. So once the inflammatory pathway is activated in COPD, it is persistent and progressive over time, and even if the patient stops smoking or the environmental exposure is taken out, the inflammatory process goes on autopilot and starts to affect not only the lung but the rest of the body as well. So there's a few theoretical points that I have to go through to highlight my points. The inflammatory process leads to an increase in the tissue volume of the bronchial wall, and there's infiltration by both the macrophages, neutrophils, as well as inflammatory immune cells. And there is now several theories which are coming into place. Why is this inflammatory process going on in COPD despite taking the risk factors out? One important study has showed that emphysema is actually an autoimmune process which is triggered by environmental factors, which characterized by the presence of anti-elastin antibodies and Th1 responses, leading to emphysema in certain people. We know that despite having the same amount of smoking pack years or the same amount of occupational or environmental factors, certain patients develop severe emphysema, and certain patients do not. They might even have normal lung function, and this is triggered by this one concept is that it is triggered by autoimmunity. There's a lot of talk about the gut microbiome and the importance of the gut microbiome in the development of autoimmunity, and now there is talk about the lung microbiome as well. And the most common bacteria which has been studied and isolated in the lungs of patients with COPD is the Haemophilus influenzae, the non-typable form. And in animal models, it has been shown that this Haemophilus influenzae non-typable form has been able to induces changes leading to COPD, leading to changes in the bronchial walls, leading to COPD exacerbations. It activates lung T cells and causes the expression of reactive oxygen species and proteases. So with this background of chronic inflammation going, let's look at cardiovascular disease and COPD. So this chronic inflammation with elevated systemic inflammatory markers of interleukin-6 and CRP affects the systemic vascular health. The chronic oxygen deprivation in COPD patient causes a compensatory cardiovascular strain, and cardiovascular disease and COPD patients have shared risk factors of smoking, physical inactivity, and also aging in itself is a risk factor for both COPD and cardiovascular disease. So, there is research into which biomarkers will predict development of COPD, which biomarkers will predict development of cardiovascular disease. And when you look at the biomarkers, when you put together, you see that COPD and cardiovascular disease both have biomarkers which are common, which are predictive of ongoing systemic inflammation and development of COPD and cardiovascular disease in a person. So C-reactive protein, a biomarker of low-grade systemic inflammation, which is associated with atherosclerosis in COPD patients, and as well as the high sensitivity CRP is associated with low FEV1 and decline in the FEV1 to FVC ratio in COPD patients. Fibrinogen levels are also another biomarker associated with COPD exacerbations. BNP, so the BNP, the brain natriuretic peptide, which is secreted when there is right ventricular dysfunction, and the amount of the increase in BMT is proportional to the severity of right ventricular dysfunction. So BNP is high in patients with COPD even without any pulmonary hypertension, and the increase in BNP level in a COPD patient has a correlation with left ventricular dysfunction as well. So the biomarkers and the pathophysiology go hand in hand. The vascular endothelial growth factor is also a biomarker of cardiovascular disease, which is also associated with COPD exacerbations. It regulates angiogenesis, promotes migration and proliferation of endothelial cells, so again affecting the same pathophysiology. Surfactant protein D, it is secreted by the bronchial and alveolar epithelial cells. It plays a major role in immune mechanisms and inflammation, and it is not only it regulates the inflammation in the lung, but is also expressed in coronary arteries, again showing similar pathophysiological mechanisms. So therefore, patients with COPD are at risk of ischemic heart disease, heart failure, as well as arrhythmias. So these I discussed. So there's a huge burden of cardiovascular disease in patients with COPD. The prevalence of systolic and diastolic heart failure ranges as high as 20 to 70% in COPD patients in different studies. And when the patient comes with acute COPD exacerbation, there may be unrecognized heart failure as well. So knowing the COPD exacerbation is driven by the same pathophysiological mechanisms driving the cardiovascular disease as well, we have to keep an eye open for unrecognized heart failure. 40% of patients needing mechanical ventilation have accompanying left ventricular dysfunction. So when you have a COPD exacerbation in a patient, we have to see whether we are optimizing the heart as well. So then when it comes to cardiac arrhythmias associated with COPD, when we nebulize a patient with bronchodilators, let's say salbutamol, when the heart rate goes up, then then people start worrying about with their sinus tachycardia, whether we can give the bronchodilators or not. So the beta-2 agonists and anticholinergics are safe. They have a safe profile except for the short-acting beta agonists and the theophylline when it comes to dealing with bronchodilation in patients with arrhythmias. So if you have a patient with underlying arrhythmias like atrial fibrillation or even stable cardiac arrhythmic disorders, you will have to avoid the SABAs and of course you know about the theophylline. So there have been trials to show so there are patients who ask whether they can use their inhalers in the background of arrhythmias. So these uplift and TIOSPER trials were large studies who looked at whether there was an increased cardiac events with the use of commonly used inhalers. So in this study, the cardiovascular safety of LABAs, long-acting bronchodilators, such as the salmeterols, the LAMAs, that is the tiotropium, the ICS-LABA combination, and the LABA-LAMA combination is well established. So when a patient with atrial fibrillation who asks you whether it's safe to take these combinations, the safety is well established. So when it comes to clinical management strategies, it is the same. So you have to optimize the cardiac management in a patient with COPD and opt for routine cardiovascular screening. So when it comes to beta blockers, again, beta blockers are an important category of medication with reduced mortality in patients with ischemic heart disease. And in this case, still studies. So there is question whether we have to avoid beta 2 blockers. We have to go for selective beta 1 blockers. Still, I was reading this morning, it is still the selective beta 1 blockers are preferred to reduce the heart strain without worsening pulmonary symptoms. So metoprolol, bisoprolol, so those groups, selective beta 1 blockers are preferred. So it goes without saying about that lifestyle modification, rehabilitation, smoking cessation, and physical activity will help both these conditions. Then we come to the COPD and interconnection of the metabolic syndrome, diabetes, and COPD. So the arrows are going here and there. There's obesity, inflammation, oxidative stress, sedentary lifestyle, smoking, all have an association with COPD, diabetes, and metabolic syndrome. So if someone comes before you and has COPD, we have to screen for the others as well, because they again have shared risk factors and overlapping pathophysiology. So there is chronic low-grade inflammation. Again and again, this word inflammation is coming into play when it comes to COPD and other non-respiratory complications. One is the low-grade inflammation, then obesity. And the sedentary lifestyle. Obesity drives the insulin resistance in diabetes and then worsens the COPD outcomes as well. Smoking, pollution, metabolic dysregulation, which increases the oxidative damage. So it will worsen the COPD as well as the other metabolic conditions. There is endothelial dysfunction in hypertension and dyslipidemia, and this microvascular injury contributes to complications in diabetes and COPD as well. So here, we can say that it's again pro-inflammatory cytokines play an important role. Hyperglycemia in diabetes impairs immune function, increasing the susceptibility to COPD exacerbations. Then hypoxia in COPD, on the other hand, triggers the sympathetic activation and worsens the metabolic syndrome and glucose metabolism. So it's very much interconnected. So implications for the management, lifestyle interventions, pharmacological strategies, multidisciplinary care is very important. So when you have a COPD patient, it is not only the physician looking after the patient, but you have to look at the heart and the metabolic conditions as well. Then next, we move on to the skeletal muscle dysfunction in COPD. This may be a neglected aspect. Well, the heart may get screened, but what about the sarcopenia? The pathophysiology of skeletal muscle dysfunction in COPD, again, the driver is the hypoxia, which leads to impaired mitochondrial function and leads to muscle fiber atrophy, especially the type 1 fibers. So then when there is loss of muscle mass and strength, that will lead to cachexia. The COPD patient's reduced activity level will also lead to muscle disuse and atrophy. Poor nutrition, we will have a discussion later on about the importance of nutrition in COPD, will exacerbate protein catabolism and muscle wasting. So the COPD patient who is dyspneic may not only be because of the poor FEV1 or the lung function. It may be because you are missing out sarcopenia or frailty that can be easily managed. Well, not easily. Well, it will need optimization. So when it comes to pharmacological management, optimizing the COPD and steroids, when for example in our patient who had exacerbations, who will get steroids from time to time, and we may be missing a muscle catabolic process which is leading to sarcopenia and breathlessness. There is evidence to say that testosterone replacement therapy may have a place in patients with significant muscle reduction, muscle mass loss. Nutritional supplements, again, we will be discussing. There are ongoing studies as to see whether these anti-inflammatory pathways can be stopped, because all of these problems are arising from this propagated pro-inflammatory pathway. There is emerging therapies for myostatin inhibitors to promote muscle growth. And then we come to osteoporosis in COPD. Again, patients with recurrent glucocorticoid use will be at risk of osteoporosis. Chronic inflammation with pro-inflammatory cytokines will enhance osteoclastic activity, leading to bone reabsorption. Hypoxemia will suppress osteoblast differentiation. Nutritional deficits, physical inactivity, all contribute to osteoporosis in COPD. So again, another aspect for us to care for in our patient, because osteoporosis can lead to fractures, and correct pharmacological options can actually help prevent bone demineralization. So in our patients, we have to. So COPD is another category of patients we have to refer for DEXA scan and also see whether they meet the criteria for bisphosphonates and anabolic agents. Patients who are on recurrent courses of steroids, we will have to go for vitamin D and calcium supplementation according to the osteoporosis guidelines. Now, moving on to the last part of my talk, the overlap between obstructive sleep apnea and COPD in patients. So our patient, in the case, the BMI was not so high. The BMI was 19. But is that patient at risk of obstructive sleep apnea? When you look at the pathophysiological mechanisms driving obstructive sleep apnea in patients with COPD, they are at increased risk of upper airway collapse. Because now you saw the chest X-ray, the diaphragms are pushed down and the lungs are hyperinflated. So therefore, the upper airway will be narrowed and pulled down, increasing collapsibility, increasing the risk of sleep apnea. Then the hypoxia of COPD will contribute to whatever sleep apnea that the patient has as a baseline. Then apart from that, the pro-inflammatory cytokines will reduce the muscle tone, which will again cause collapse of the airway more in a patient with COPD. So therefore, even if your patient is does not look typical of an OSA patient, even if they are not so obese, they are still at risk of obstructive sleep apnea. So therefore, COPD and OSA together are called an overlap syndrome, where we have to look out and diagnose, because unless it is corrected, it itself will contribute to severe hypoxia and nocturnal hypoventilation. So again, we come back to the same management steps of managing, improving nocturnal oxygenation, improving the COPD, reducing the systemic inflammation, and screening and treatment of the obstructive sleep apnea patients with the standard CPAP therapy. If there is hypoventilation in the overlap with the COPD and obstructive sleep apnea, then we will have to give them bi-level positive airway pressure. In the absence of obstructive sleep apnea, but if there is only nocturnal hypoxia in the patients with COPD, they will meet the criteria for supplemental oxygen. So this is an outline of the non-respiratory complications of a patient with COPD, that we have to not only look at the lung, but the other organs as well, which are just as important. Right, thank you.
Thank you very much for that comprehensive overview of the complications of COPD. Ruwanthi, what do you think about the psychological aspects? I think there was no time because a lot of these people are depressed and they're anxious, and that has a very bad effect on the disease management.
Yes, that is also an important aspect. Because of lack of, there's psychological disorders, then there are the other hematological disorders. There are so many other aspects when it comes to like polycythemia, for example, which, so COPD is not only confined to the lung, and it has, all the systems are getting affected. And when it comes to anxiety and psychological disorders, this will in itself contribute to inactivity, which again will go into a vicious cycle. So I think there are screening tools which can be used when we come with patients to diagnose underlying conditions.
I think it is very important to understand the complications of COPD, because in management, very often we manage only the COPD, but very often these people have lots of other problems which are not diagnosed, and we don't understand them either. So you find the blood sugars going up there in LVF, and the pulmonary hypertension is out of control, and all these kind of things. So management of all these conditions are very important. I think if there are no other questions, we will conclude this session now.
Thank you very much to all the panelists for that very comprehensive and engaging session. Ladies and gentlemen, with that, we'd now like to move on to the third and final session of the specialty update on respiratory medicine. While I invite the panelists on stage, maybe the audience can stretch your legs and refresh for this final session. I'd now like to invite on stage Dr. Ravini Karunatillake, the consultant respiratory physician at the National Hospital of Sri Lanka, Dr. Samanmali Dalpadatu, consultant respiratory physician at Teaching Hospital Karapitiya, and Dr. Gauri Samarasekera, consultant nutrition physician at the Colombo North Teaching Hospital. I'd like to invite Dr. Paba Attapattu, Senior Registrar in Respiratory Medicine, to commence the session.
Good afternoon, everyone. I would like to thank the Ceylon College of Physicians and the College of Pulmonologists for giving us this opportunity. I won't keep you for too long. It's way past your lunchtime, so we'll try to keep it quick. So we've been given the topic of advanced COPD and would like to mainly focus on long-term oxygen therapy, a long-term home oxygen with non-invasive ventilation, and palliative care. So moving on to our patient that we encountered at clinic. So Mr. S, a 68-year-old gentleman, a retired sand miner, who's an ex-smoker with a 15-pack year history, diagnosed patient with COPD for the past 15 years. He's very short of breath when attending to activities of daily living and debilitated due to his illness with an MMRC score of 4. He's currently Gold Class 4, Group E, with a history of diabetes and hypertension with a Bode index of 9. So he is currently on optimal medical care with good compliance and medication, and he's on dry powder inhaler of Astellin, Seroflow, and Tiova because he finds it difficult to use metered dose inhalers. However, despite optimal medical therapy, the patient is experiencing severe dyspnea with a resting saturation of 89% with multiple hospital exacerbation around 4 to 5 a year. He has attended the pulmonary rehabilitation program, which he has found helpful from time to time. Now moving on to long-term oxygen therapy. So we would like to base our discussion on the following, trying to answer the following questions. So what is the basis of hypoxia and hypercapnia in COPD? Who should be referred for LTOD? What are the indications for LTOD? Does this patient qualify for LTOD? How do we prescribe LTOD and the precautions when using it? What are the benefits? And also the other forms of home oxygen and the obstacles in giving LTOD. Now I would like to invite Dr. Ravini to the podium.
So thank you, Papa. Yeah, so we are hoping to answer some of these questions. So we go on to what is the basis for hypoxia and hypercapnia in COPD. So if you can remember of what was told in the morning, you'll know that there are two main problems with COPD. One is an airway obstruction, and the second is the destruction of the alveoli surface. So the airway obstruction is actually caused by excess mucus production, ciliary dysfunction, airway remodeling, which we heard of, and damage to the alveoli, losing their elastic recoil. All of this makes the lungs find it difficult to exhale. In addition, there is a problem with gas exchange. There's loss of alveolar surface and destruction of the capillaries, which impairs the oxygen and carbon dioxide exchange across the alveolar membrane. Now, this leads to what we call as ventilation-perfusion mismatch. And this is where it starts occurring, the hypoxia, and in advanced stages, the hypercapnia. In addition, the dynamic air trapping and the hyperinflation causes respiratory muscle fatigue, and the patient starts reduced sensitivity to carbon dioxide, which is the principal driver of ventilation. And we heard about the comorbidities. This also adds to the respiratory compromise in these patients, especially the obesity and the sleep-related breathing disorders. So, does it end only with the lung? Not really. Because of the chronic hypoxia, there are a lot of vascular changes that happen in the pulmonary vasculature. There is endothelial dysfunction because of a similar kind of inflammatory response that you see in the lung occurring in the capillaries. There is also vascular remodeling, again similar to what you see in the small airways, and all of this leads to increase in the capillary vascular resistance and causing a pulmonary hypertension and eventually going on to right heart failure. So, keeping this in mind, we know that hypoxia is detrimental. So, who should we refer for long-term oxygen therapy? So, for you, when you come across a COPD patient whose saturation is less than 92%, equal or less than 92%, they should be referred for long-term oxygen therapy. But having said that, if there is any evidence of onset of pulmonary hypertension suggested by either on an echo, or there are overt signs of right heart failure suggested by peripheral edema, or there is polycythemia, then the saturation level goes down to equal or less than 94%. So please remember, next time, check your patient's resting saturation, the stable COPD patient that we talked of, and see whether it is either less or equal or less to 92% or equal or less to 94%. And when you refer this patient to us, we do what is called as a LTOT assessment. Now, this is done only if the patient has been stable for the last 8 weeks from his last exacerbation. And what do? We do 2 arterial blood gases, which is done 3 weeks apart. And then we decide whether this patient is eligible for LTOT. So what is the criteria? The criteria is arterial hypoxemia defined by an PaO2 less or equal to 55 millimeters of mercury, or as I said earlier, if there is any evidence of right heart failure or erythrocytosis, then it becomes more than 55 but less than 60 millimeters of mercury. So the threshold goes down. So in our patient, does he qualify for LTOT? So his pH is 7.33, his PCO2 is increased, his PO2 is within the criteria to be prescribed for LTOT. And there is also evidence of mild pulmonary hypertension on the 2D echo. So then we ask the question, right, if we repeat the blood gas and he has the same criteria, then how do we prescribe LTOT? So we bring the patient in and we start a flow rate of 1 liter per minute and titrate it by 1 liter per minute with increments every 20 minutes so that we reach a SpO2 of more than 90%. And what we are at the point when we reach our target, we have to repeat our arterial blood gas to make sure that we have reached a PaO2 of more than 8 kilopascals or 60 millimeters of mercury. Now, remember, we can drive these patients into type 2 respiratory, worsening their type 2 respiratory failure. And if you can remember your previous patient that we talked of, his PaCO2 was high. So he's a vulnerable patient where we can worsen his type 2 respiratory failure by giving oxygen. So therefore, that is why at the end of titration, we need to make sure that we have reached our targets, but we have not worsened his type 2 failure. And then when we do ask this patient, okay, this is your oxygen titration, this is what you need to use at home, then he needs to be on it for more than 15 hours for the day for the best benefit of giving LTOT in patients with COPD. And of course, if there is no risk of going into type 2 respiratory failure, we ask him, okay, increase your oxygen titration by another 1 liter per minute overnight during your sleep. I'm sorry, I think did I not show that slide? Okay, so sorry. So now that we have prescribed, what are the safety risks, and risk considerations that we need to have? If a patient is smoking, it is almost mandatory to ask him to stop smoking, and because there is an increased risk of fire. If he refuses to stop smoking, then you have a right to refuse giving LTOT. Or you could discuss with the patient about the pros and cons of home oxygen, especially if there is a person at home who is smoking and is refusing to give up. So it is a discussion that has to happen because there is a considerable risk, fire risk, when a person is actively smoking. Of course, the patient needs to be educated on the equipment and also on the safety, and we use what we call as an oxygen conserving device to optimize the mobility of the patient. So the better option for home oxygen is an oxygen concentrator, and a portable device can make the patient's mobility, because for 15 hours it's very difficult to stay in one place. It can be used overnight during sleep, but during the daytime it is important that we consider that we do not confine the patient's mobility. The preferred device is a nasal cannula, but if there is any risk of hypercapnia, then we prescribe a Venturi mask. So what are the benefits of LTOT? Clearly, it reduces the pulmonary vasoconstriction. It mitigates the polycythemia, and I think Ruwanthi did make a mention of the comorbidity of having polycythemia. Though polycythemia is initially beneficial, later on it can cause increased blood viscosity and then impair the microcirculation. LTOT also enhances cellular function, especially in the muscle, where the muscle usually goes into anaerobic pathway, now can have aerobic energy production when the patient is on LTOT. It alleviates systemic effects of hypoxemia, such as cognitive decline, skeletal muscle dysfunction, and impaired cardiac function. And I think we have heard how hypoxemia has detrimental effects on these organs. But the best and the most promising effects of LTOT is that LTOT reduces the frequency and the severity of exacerbation and improves the overall survival of your COPD patient. So we talked about long-term oxygen therapy where it has to be given at least 15 hours or more for the day. But can we all afford to give LTOT, and are the patients all agreeable to taking LTOT? It has a lot of restrictions, especially within our community. So there are other forms of home oxygen that we can give. And I'll introduce you to three concepts. One is the ambulatory oxygen therapy, palliative oxygen therapy, and short burst oxygen therapy. Now, none of these are evidence-based, but this is the form of oxygen that we are giving mostly out to our patients. Now, ambulatory oxygen therapy is given to very ambulatory patients or patients who have active lifestyles who need their oxygen to go along with them. Now, ambulatory oxygen therapy, as per evidence, is only for patients who are eligible for LTOT. It should not be given for patients who are not on LTOT. Now, palliative oxygen therapy again has no basis, but you can give palliative oxygen for patients who have intractable dyspnea, but they still need to be hypoxic. You cannot treat dyspnea by giving oxygen. So their threshold for LTOT, which is when their SpO2 is less than 92%, that has to still be there for you to prescribe palliative oxygen. If a person is dyspneic, but his oxygen is not hypoxic, then the next best option would be to consider this patient for opioids. And I'll introduce you to that later on. Now, the short burst oxygen therapy is again a form of oxygen therapy that we prescribe, which is in relation to a particular exertion. So if a person is very dyspneic, the first thing that will probably happen is that he will limit his physical activity, and we know that that is not good. There is what we call as a spiral of disability that sets in when the patient gets limited by physical activity. So we want to encourage our patients to move around and at least to attend to their activities of daily living, where that is where the quality of life is sustained. So here we give them short bursts of oxygen in relation to a physical activity. You could say, for example, somebody needs to go and bathe and it really is a struggle to do so. Then we can ask them, pre-oxygenate yourself, go and have a bath and come back and oxygenate again for a short period to recover from the exertion. So I'll ask Baba to tell you about our LTOT, our home oxygen service, which we have been running from at the Central Chest Clinic for the last 2 years, and she'll present a little bit of data on that and also a little study that we have done thus far.
LTOT and short burst oxygen therapy is currently provided by the Central Chest Clinic in Boralla. And over the past 2 years, we've given around 98 machines on a loan basis to patients who are eligible. So currently, for COPD, we've only given around 13 machines, but for other chronic respiratory conditions such as ILD, bronchiectasis, we've given them machines. The next is a small pilot study that was conducted at the Central Chest Clinic in Boralla, where a cohort of 27 patients were recruited with chronic respiratory conditions from various demographics who fulfill criteria for home oxygen. So the study is still ongoing. So therefore, the preliminary results, it's mainly a survey-based study, show that there's a statistically significant improvement in shortness of breath, quality of life, fatigue, overall well-being, and a reduction in stress and anxiety in patients who received LTOT. Next, we would like to move on to long-term home oxygen with non-invasive ventilation. And the outline for the next session would be, why is long-term home oxygen or NIV important? What are the evidences and recommendations? Does this patient qualify for home NIV? How is the patient evaluated for home NIV? And how is it set up? And what are the monitoring protocols and the advantages of home NIV? I'd like to invite Madam.
Yeah, so the just a word on the home oxygen. So you're most welcome to refer your patients. Of course, the biggest obstacle that we have had with home oxygen is that the patients are unable to afford. There is a increasing cost of electricity bill depending upon the usage of these concentrators, and so we are unable to meet all expectations of giving LTOT, but we do manage to give short burst oxygen and palliative oxygen to these patients. And as you can see, as the study is showing us, there is an improvement, not maybe in the survival, but in other factors that seem to be important to patients. So the next is on long-term home NIV. So similar to hypoxia, hypercapnia is also a determinant of mortality. And correcting this hypercapnia may be an important intervention aiming at improving the prognosis of your COPD patient. So how does NIV work under these circumstances? It reduces the lung hyperinflation, and I spoke about dynamic hyperinflation. So NIV helps in reducing the lung hyperinflation. It reduces the respiratory muscle workload, especially on the diaphragm, and it increases the ventilatory chemosensitivity to carbon dioxide. So their ventilatory drive improves. There are two multicenters, one multicenter RCT and another smaller study that I want to quote. And this shows that for patients who are in type 2 respiratory failure who were given either LTOT or home NIV with LTOT and targeting a reduction in the carbon dioxide by 20% from baseline has shown that it improves the 1-year survival by when the patient is given home NIV plus LTOT. So clearly there is a survival benefit in patients with home NIV. It also causes an overall reduction in the hospital admissions. And it especially again there's a smaller trial, but these evidences are not very robust. So the ERS task force has given a conditional recommendation for NIV in the setting of stable chronic hypercapnic COPD patients. So how they have argued this is that though the evidence is not very robust, there is some signs that it improves the quality of life, it improves dyspnea, and it improves the exercise tolerance. And there is low to moderate evidence that there is also an improvement in survival and exacerbations. So the argument is that these patients, the overall benefit is felt to outweigh the potential harms. And we know that these COPD patients with a lot of comorbidities, that the survival benefits of any form is important for them. So the ERS task force is giving us this conditional recommendation, and it says that when you are giving home NIV, that we need to titrate it to normalize or to reduce the PaCO2 levels, and that would be the best possible outcome for these patients. So, what are the criteria for home NIV? We know that it is chronic hypercapnic respiratory failure, post-hospitalization, like the patient we saw earlier, who are still hypercapnic, frequent exacerbators, if there are persistent symptoms, and like earlier, overlap syndromes, and if there are blood gas indications, especially when the PaCO2 remains more than 52 millimeters of mercury, and when LTOT alone becomes refractory. So, can I be given another 5 minutes? Yeah.
So the story of our patient continues. His primary caregiver is his wife, who's a retired teacher. They live off their pensions and is financially stable due to their savings. And they have 2 children who are both married and living away, and parents do not receive emotional support. He's a devoted Buddhist. Since his last admission, he's worried about his wife in case something is to happen to him. So he's quite anxious about it and suffers from depressive symptoms frequently. In spite of optimal medical care, he has marked shortness of breath with productive cough, which disturbs his sleep. So now we would like to move on to palliative care. It's a whole topic on its own. However, we would like to touch base on how it would affect patients with chronic respiratory illnesses. So we would like to discuss the definition of palliative care. When should you offer patients palliative care inputs? What are the goals of palliative care in this patient? And palliation of breathlessness.
Yes, I didn't want to forego this little bit because I think this is the most important part of my talk. That if we do not understand that we need to improve the quality of life of these patients, the survival, the exacerbations, none of these actually matter. What matters to the patient is that he has a good improvement in his quality of life, relief of suffering, and so that is the basis behind palliative care. So what it aims to do is to improve the quality of life by preventing and relief of suffering. And when you talk about suffering, it happens in many domains. It's not only the physical suffering, it's the psychological, social, and the spiritual suffering that a patient goes through. So it's important that we have a holistic approach towards these patients. So very briefly, I will tell you, if you are to identify your patient who needs palliative care, it's important that you know what our illness trajectory is. So the one on the left diagram on your left, right in the middle, shows the functional outcome of patients over time, especially in patients who have organ failure. Whether it be heart failure or renal failure or respiratory failure, these patients have a gradual decline in their functional status over time, and the little dips that you see, those are the exacerbations. So eventually, towards the end of life, there will be more frequent exacerbations, but death still seems quite sudden. So in that event, how do you predict a patient requiring palliative care? So the diagram on the right tells you what is the better concept of introducing palliative care, which means for patients who have life-limiting or life-threatening illness, it is best to introduce palliative care right at the beginning of the illness. And maybe the palliative needs may not be that much, but as the time goes by, you can start then increasing your palliative inputs, which then gets extended beyond the demise of the patient to the care of the remaining family members. So then you'll ask me, okay, what is the practical way of approaching palliative care in these patients? So for my practical purposes, I ask what is called as a surprise question. If there are patients who come to you and you ask yourself this surprise question, would I be surprised if this patient is not alive in 6 months? And the answer is no, I will not be surprised. Then pick that patient up. That is the patient who has the most amount of palliative needs. What do we hope to do? We hope to give a holistic care. We keep the patient in the middle and the family. We continue the disease management, but we also look at physical, psychological, social, and spiritual aspects that are attributing to the suffering of this patient. We look at the practical ways of implementing this. We look at end-of-life care, which is very important, and then deal with the grief and loss of the family members. So in this patient is just quickly, I'll probably go ahead. So just to quickly tell you, he has marked breathlessness, which is a physical problem to him, and his cough. His psychosocial problems are he's worried about his wife, he has depressive symptoms, and he's unable to enjoy any form of leisure activities. And the spiritual problem he's having is he's feeling guilty that he's no longer able to engage in spiritual activities. So this is an actual patient. We have not made up a patient for you. This is actual problems that a patient has gone through. So very briefly, just remember, breathlessness is not hypoxia. Breathlessness is a perceived sense of difficulty in breathing, and it is multifactorial. And the reaction to breathlessness also is very individualized. So we talk about breathing, thinking, functioning cycle when we talk of breathlessness, because there are many elements to breathlessness than just hypoxia. I'm sure all of us have felt breathless at some point, especially when we are overly anxious. So there is a huge anxiety component that drives your breathlessness. If you don't identify that in your patient, you will just be adding on a lot of pharmacotherapy without really addressing the driver of breathlessness. Then there is the breathing cycle and the functioning cycle. So due to lack of time, I will not go on to this, but you need to at least the bare minimum of your assessment should try to understand, like what Dr. Kanthi Nanayakkara was saying, there is an anxiety and a depression which is very prominent in our COPD patients. And this anxiety may be the reason why the patient repeatedly talks about his difficulty in breathing and why he keeps coming back to you to the hospital, back and forth to the clinic. If you do identify these problems, then there are strategies that you can take. And one of those strategies we'll be dealing with later, which is pulmonary rehabilitation. But there are a lot of non-pharmacological measures that you can take. And you can finally consider opioids versus sometimes just the oxygen that you give to the non-hypoxic patient. So opioids really are ones that mask the unpleasantness of breathlessness that patients feel. And as per the goal guidelines, we know that it is very important that palliative care gets introduced to your COPD patient, and that end-of-life care planning is also mandatory if you are giving a holistic care. These are my references. So when you're at the end of all of your high-end treatment modalities, I would say there is also another path that you can take to comfort and care for your patient. Thank you.
I'd now like to invite Dr. Samanmali Davadata, consultant respiratory physician at the Teaching Hospital Karapitiya. Over to you, madam.
Thank you. It is time past for the lunch, and now you are also depressed because Dr. Ravini is talking about palliation, isn't it? So, so far, since 2 hours lecture, are you convinced that COPD is a lifelong disease? Everybody is convinced. Is that? Yes. Are you feel that it is a disease of elderly? How many feel that this is a disease of elderly? No, it's not a disease of elderly. It's going to be a lifelong disease, but it can start from the middle age from onward. So they have to live with the rest of their life with the COPD diagnosis. So from that, I'll start my presentation. So I think it's a very good case that Dr. Ravini has discussed. But if that particular patient has sent for the pulmonary rehabilitation at least few years before, we would have avoided all these consequences, giving oxygen, giving BiPAP, and finally sending for palliation. This is where this pulmonary rehabilitation is sitting for. So early detection and sending the patient for pulmonary rehabilitation has got high evidence now. It's evidence A according to the goal guideline. It reduces the dyspnea. Not only that, it reduces the mortality and morbidity. That is the main thing that we have to keep in our mind. So I am not going to take a long time. So if that particular patient is sent us, what would have been done? So our nurse first catch him and say, doctor, the patient is on DP inhaler, but very poor inhaler technique. Very poor. So he has been using this inhaler for 5 years, but to see that his throat is impacted with the dry powder. So we have to correct it. Nurse will alarm because that nurse has got so many experience with the patient. So she start with that. So she teach the technique, and same time she makes sure that each and every visit to the rehabilitation program, patient is repeatedly checked for the inhaler technique. So make sure by repeated teaching and repeated demonstration that patient is now taking proper inhaler. By doing that, you could continue to give the steroid via the inhaler technique and reduces the inflammation in the airway and reduces the requirement of oral steroids here and there. By reducing that, you overall increase the prognosis, isn't it? So reduce the exacerbation risk. So like that, first thing that in our rehabilitation program, we do the correct inhaler technique and correct drug use. Then in patient view, patient is now depressed because now he is given a COPD diagnosis. In singular, they might have said, your lung is damaged. He doesn't know what the damage word. So he is now anxious. Now he thinks that now I am 67, 65. So now I am old. So this is a disease of elder population. So I am now going to die because my lung is damaged. So he's anxious. Nobody is talking about these things with him. He just said, your lung is damaged. Doctor, what did I have? Your lung is damaged. That's all. So patient doesn't know anything. So he's now anxious. And he can remember that he has smoked in the past. So he has got a feeling of self-guilty. Family also tells, you have smoked in the past, so now he feel very guilty. When you go to any doctor, they ask, have you smoked? Then they start writing. So doctor face is like, it's like doctor doesn't tell anything, but the facial expressions are not nice. So now the guilt is added. Then when the patient comes to the rehabilitation program, there are so many people around him who has already smoked. Now he can talk and he can share his thoughts, isn't it? So everybody is just in similar background. So now he is relaxed, he can talk. And now he know that not only because of the smoking, but because of the past job, he has exposed to the unexpected dust exposure. And it also caused this lung disease. Now he is little feel happy, and his guilty feeling has gone. Now he is little proud because I have worked and got this lung disease. I have worked for my family. Now I got this lung disease. So with that, now he's a proud person, isn't it? So his family social interaction is now improved. So he is happy to do whatever we say. Then when the rehabilitation starts, he starts his muscle strengthening exercises, which he has stopped for ages. Now his muscles are little getting strengthened. So now the mitochondria, whatever that we were talking about from the morning, now it's got reverse cycle. And that vicious cycle is now reversing, so that the shortened muscles, muscle fibers, mitochondria, everything is now getting back to the not to the previous level, but to some extent that now vicious cycle is now getting reversed. So now when he is doing work, he is not getting anoxic that lactic acidosis production, which causes fatigability and difficulty in continuing exercise. So he can do some exercises. Now he thinks, yes, I have to do, I will do, I am doing. So like that, he start motivating and getting physical exercise one by one. So for that, our physiotherapists are helping, and she has given a plan for each and every week to increase the exercise capacity. So like that, he is now with us since for last 8 weeks. So now he feel that now he can go out, which he avoided because he feel that because his weight was lost, his face is different now. Earlier, so people are not very recognize him. They ask why you have lost weight. So many questions when he go out. But now he has confidence, so he go out. He walk and he try to sometimes he try to ride bicycle, something like that. So now he's happy and he meet his friends now. So now he has a social life. With that, we don't want to bother him that now he is back to his normal happy life. So he adherence will be maximum and he will continue to do his normal work. By doing that, the pulmonary rehabilitation aim is to continue exercise will be happen. So that is what the experience which I had for the last 5 years when we do in the pulmonary rehabilitation program. So I'll go with the very quick presentation. So that is what pulmonary rehabilitation is. It's a comprehensive intervention based on a thorough patient assessment, followed by patient-tailored therapies, which include but not limited to exercise training, education, behavior change, designed to improve the physical and psychological condition of people with chronic respiratory disease and to promote long-term adherence of health-enhancing behavior. It's a multidisciplinary team effort. So, as we said, it's a dyspnea inactivity is a vicious cycle which is broken by this rehabilitation program. So, it happens like this because patients has dynamic hyperinflation in COPD. They had a very poor exhalation time. So you start them to take the deep exhalation period. So your dynamic hyperinflation will start reversing. So their tidal volume will be increased. So they feel that their breathing is comfortable. Even in the anxiety, if you are trained, they will follow that. So their anxiety will reduce. So I just showed this. When the patients come to you, will be in the third person, but maybe you can build at least not as the previous person, but in between person, while giving all these as my previous speakers told that how much the COPD has impact to the other system. Mainly my focus is skeletal muscles, which I showed in this picture. It will be, if it is disuse, we get disuse atrophy. Because of the drugs, maybe steroid causes harmful effect. So all this causes significant wasting of the skeletal muscles and dysfunction. So even within years, they might change their appearance. If you clearly observe them, their clothes might be hanging. Because within years, they lost significant weight, mainly their muscles, skeletal muscles. And same time, it affects the ventilator muscles as well, breathing muscles, everything affect. But in every patient is not affected in similar way. There will be different. Patient is different. Their muscle strength will be differently affected. So you may see some people's quadriceps are affected. So they might find difficulty in climbing stairs. Some might the upper limbs are affected. They might find it difficult to carry something like for example, I had one patient. She's like 30 plus. She had a problem with carrying her child. So just after rehabilitation, she was telling us with a smiling face that now she's carrying her baby. So something like that. So that is the thing that they are expecting. So how to set up a pulmonary rehabilitation program? It's a very cost effective. If it is done within the existing program, existing infrastructure and equipments. We have done a research a few years ago saying comparing the available equipments like sandbags, whatever we can find in local settings will be equal to the rehabilitation program which are in the internet. That they use some machines, but we didn't have any, but we have a locally available things, but still the prognosis that the outcome was significantly improved. So it can be done. We have to exclude people like aortic stenosis, joint disorders, so even after acute exacerbation, we can take these people. So we have to have an exercise prescription. It is individualized depending on the patient's, as I said, their muscles groups are involved differently. So depending on that, we have to find a different exercise prescription. It is the specialty of the physiotherapists. They do it. So they do this. Actually, it should be done after a shuttle walk test and see the heart rate rise, and then they have to make a exercise prescription, and each and every week it has to be increased according to the patient's ability. So with the minimum at least 8 weeks, when you start this pulmonary rehabilitation program, you do everything together. So they are given at least 30 minutes exercise should be their program. It's good that it can be increased. So there are some criteria which we have to follow. Minimum 8 weeks, more than 30 minutes of the exercise trainings, those things. And there will be expected goals like pre 6-minute walk test. The post 6-minute walk test should be more than roughly, it should be improved. It depends, but maybe 30, 40, 50, we have seen maybe hundreds. So dyspnea scale should be increased. I mean, that is how you quality assess your rehabilitation program. So this is a multi-system involved disease. So when you start attacking these independently, patient has to go to several places. For example, if you are sending the patient for the smoking cessation, the smoking some psychiatric clinic, and then to the nutrition part to the nutritionist, so they have to come to several clinic appointments. But with particular this rehabilitation program, we are ready. Patient comes and get all this in one place for consequent 8 weeks, and they finish it. So I think that efficiency is more when we establish a rehabilitation program compared to the other ways of doing the same thing. For the dietitian, she's next lecture will be done regarding the nutrition. But in our case, in Sri Lanka, there are so many myths. SEMA, the food causes SEMA. There are so many. So each and individual patient has their own ways of addressing these nutrition issues. So we have to talk each and individual and keep in mind of their BMI. And psychotherapy, yes, it's a very important thing. So it goes parallelly, and normally when we do the rehabilitation, there are 4 weeks we talk about the psychotherapy aspect, and 4 weeks we talk about the nutrition alternatively. So that's how we do this 8 weeks program. So by respiratory nurse, she is the overall in charge. So she knows most of the patients by their because the patients, as I said, COPD is a lifelong disease. So they have frequently visits to the respiratory units. So even then, medical board people can refer to the patient, definitely yes. So they will be like a family. So respiratory nurse will do that, keeping people in one group, and so that is how it is happening in our setting. So finally, we want to increase the quality of life questionnaire as well. So if we reach all this goal, we'll finish by 8 weeks. That is how it happens. This is a few pictures from our rehabilitation program. So I would like to thank my team as well. So thank you very much.
And finally, I'd like to invite Dr. Gauri Samarasekera, Consultant Nutrition Physician at the Colombo North Teaching Hospital. Over to you, madam.
Thank you very much, organizers, for giving me this opportunity. And I will not take much time because I think most of my slides are covered by Ruwanthi. So I will just discuss how you optimizing nutrition in COPD by nourishing every breath. So basically, that nutrition depletion or in COPD discussed by Ruwanthi and all, and aims of medical nutrition therapy will be discussed, how to identify malnutrition, because this is a broad aspect of COPD that should be incorporated into the protocol, and key nutrition recommendations I will touch upon, and protein and exercise synergy. So nutrition depletion in COPD, there are several phenotypes: sarcopenia, cachexia, frailty. I don't go into details because Ruwanthi already covered it. So ultimately what happens is the functional disability, as Dr. Samanmali said, patient will be deteriorated by physical performance. So causes of muscle wasting in COPD, again, I think Ruwanthi covered most of the things, and ultimately by every means, anorexia, systemic inflammation, chronic inactivity, hypoxia, and decreased testosterone, ultimately with the corticosteroids, the muscle mass will be decreased. Basically, the fat-free mass will be decreased, especially the type 1 fibers. So ultimately associated with higher motility, reduced lung function, muscle weakness, and recurrent admissions with exacerbations. So that is the most important thing. If you can incorporate into the protocols how to identify malnutrition with a comprehensive nutrition assessment, I think we have to focus on fat-free mass basically, because board index and everything is good, but we should not go with the BMI solely, because that will not give you a better idea about the fat-free mass. So since the obesity is a global pandemic in the current scenario, we can't exclude COPD patients, because obesity prevalence in COPD varies between 18 to 54%. But the thing is, they are sarcopenic obese, because even though they are within the normal BMI, they can be sarcopenic. As Ruwanthi said, the obesity will be associated with cardiometabolic risk factors with high waist circumference. But at the same time, if we evaluate the fat-free mass by using body composition analysis, that they will be sarcopenic. But having said that, we should not forget about the obesity paradox in advanced COPD patients. As you can see, that the significant reduction in mortality in patients with moderately obese when they have advanced COPD. So aims of medical nutrition therapy or targeted nutrition therapy, I think we have to preserve or increase the lean body mass and stabilize the weight. As Dr. Samanmali said, our therapeutic target should be 2 kg weight gain by pulmonary rehabilitation at 8 weeks. During acute exacerbation, of course, we have to minimize muscle loss and weight loss and improve immunity. But on the other hand, if we can increase 2 kg over 8 weeks in depleted COPD patients, that they have there's evidence that improves survival at 4 years. So key nutrition recommendations, I will not go into detail by telling energy, protein and carbohydrate, but that has to be incorporated into the pulmonary rehabilitation with micronutrient, because there are multiple micronutrients come into play to increase the muscle strength as well as the exercise capacity, especially vitamin D and antioxidants, vitamin C 400 milligrams with iron, screen for an address deficiency to prevent fatigue and support oxygen transport, with other minerals like calcium and good quality proteins. So key nutritional recommendations will come into play with targeted personalized medical nutrition therapy. So protein, actually we already know that egg protein has the highest amino acid score with 100%, but we can give them the good quality protein by incorporating the locally available things into their diet by counseling them adequately. So we should not forget, as Dr. Samanmali said, protein and exercise synergy, because when it comes to physical exercise and protein ingestion together, they can activate the mTOR pathway, which increase the muscle anabolism. So all that is aiming to preserve the lean body mass. So why I put this one is, this is not very evidence, not thoroughly recommend to use these things, but the beetroot juice. So they recommend that there's a potential benefit of giving beetroot juice with 12.9 millimoles, because it's very rich in nitrate. If we can give twice weekly, 3 hours before the pulmonary rehabilitation program for 8 weeks, not for a long period, that will increase the exercise capacity. There are double-blinded, randomized crossover studies with placebo control. They have proven that this might helpful. So in our setting, that especially poor resource setting, I think this can be something we can think about in our future research in pulmonary rehabilitation programs. So ONS, yes, definitely, as you can see in this forest plot, there's a definite benefit over giving oral nutrition supplements, but economical limitations in our settings due to financial limitations. So that has been giving oral nutrition supplement is bit difficult in our setting due to our financial constraints. But having said that we have Triposha in our clinics, which 100 grams of Triposha gives you 400 kilocalories and nearly 18 to 20 grams of protein. So something we can think about. So I'm telling the practical aspects in our setting. So general dietary advice at any clinic that you can give is giving them frequent small meals will help to alleviate dyspnea and fatigue, soft, easily chewable foods, and we have to encourage them to have more breakfast, because if feel tired at the latter part of the day, and if early satiety and abdominal fullness is present, drink water 1 hour after meal, like some practical points. And late night snack, actually we can give Triposha to increase the muscle anabolism. So that's all I think regarding the nutrition advice. So if you have any questions, you can ask. Yeah, they say it's 100 ml nitrate rich, 12.9 millimoles concentration, but I don't know how to that has to be
100 milliliters of puree of beetroot.
Yes, yes, but not for that. Evidence suggests that not for a long term use, but for 8 weeks. That basically pulmonary rehabilitation, it goes over 8 weeks program. So that has to be further study and can be in our setting. I think we can actually think about it.
Specific substance that will help that, right? Beetroot. Any specific substance in the beetroot?
Nitrates, yeah, exogenous nitrates.
Would it increase the blood sugar?
I don't think so, sir. It's very rich in potassium, but not,
Sorry.
But there is a virtual question from a question from a virtual attendee asking whether we are giving home oxygen in the government sector. So I just wanted to clarify that. Yes, we do give home oxygen. We have a provision of giving oxygen concentrators. It's happening in several centers across the country. So if there are a respiratory physician, I think you can have a conversation about getting home oxygen. There are limited number of concentrators. So so it is selected. But yes, if there is an option of getting home oxygen through the government sector free of charge.
Thank you very much. With that, we conclude the third session of today's specialty update. Thank you very much. Ladies and gentlemen, our final session will be a virtual talk delivered to you by Professor Dushantha Madagedara on COPD in non-smokers, a growing epidemic. Professor Dushantha Madagedara is the chair professor of medicine at the University of Coimbatore and consultant respiratory physician attached to the National Hospital, Kandy.
Good afternoon. First of all, I'd like to thank the organizers inviting me to present this very important topic today, non-smoking COPD is growing epidemic. This symposium is organized jointly by our colleague and Sri Lanka College of Physicians. I think you heard several aspects of COPD from morning to now, and I was given the task to talk on non-smoking COPD, the growing epidemic. It's another important aspect we need to give emphasis on the COPD and its management. As you well aware, COPD, the chronic obstructive pulmonary disease, refers to the group of diseases that include chronic bronchitis and emphysema. It is still a very important disease when you talk about the mankind, where it causes 3.23 million deaths in 2019 due to COPD. 90% of the COPD deaths in those under 70 years of age occur in low and middle income countries like ours, where the Southeast Asia and Africa and South America. COPD is the 7th leading cause of poor health worldwide. And when you talk about the COPD, the etiology, 70% of the COPD cases in high-income countries are due to smoking. However, in low middle-income countries like ours, smoking accounts for 30 to 40% of the COPD cases. And the balance is due to non-smoking causes of COPD. When you talk about the various causes, it is now clear that tobacco smoking in adult life is not only the cause of COPD. There are several other risk factors as recognized in considering the etiology of the COPD. Namely, the female at birth, age over 65 years, exposed to indoor and outdoor biomass fumes and the air pollution in adult life, poor lung growth, both before and after birth as a result of malnutrition, infection, so on, and exposed to those factors increasing in the most low middle income countries, and urbanization, deterioration air quality are equally important in those countries. When you talk about the prevalence in non-smokers, COPD prevalence in non-smokers, the prevalence and incidence of COPD in smokers and non-smokers. The Rotterdam study 2016 has shown that in ever smokers, 17.8% had the COPD in this particular study, and never smoker or the non-smoker had 6.4%. In men, it was 17.3%. The never smoker compared to 46% never smoking women. In other words, if there's a female predominance compared to male sex in the non-smoking COPD. This graph, same thing highlighting where the never smoking men and the never smoking female, it has shown the significant number in the female sex. During 2013 and 2017, an estimated 2.4 million US working adults aged over 60 years who never smoked had COPD. So it's a quite significant proportion. The highest COPD prevalence among the person who never smoked found in this particular study, the information technology, mining industries, and office and administrative support occupation worker, 3.3. So in the different occupational group, are at a risk of developing COPD. Among workers who never smoke, the highest COPD prevalence were among women, 3%, and the adult age more than 65. In other words, female sex and elders are more predisposition for non-smoking COPD. Finding of high COPD prevalence among workers who never smoke corroborate finding that occupational exposure in addition to smoking might be associated with the development of COPD. The small study, Mahmood et al., so the prevalence and etiological profile of COPD in non-smoker 2017 show that non-smoker had a higher percentage, although this is a small cohort compared to the smokers. This study further has shown that the TAN YC SINDD published in Thorax 2015 showed that various risk factors they have recognized in the never smokers, namely the organic dust exposure, inorganic dust, gases and vapors, biomass fuel, and passive smoking at home, comorbidities like asthma and COPDs, and these are they have recognized compared to smoker and at a high significant proportion. Now there are many causes have recognized in the COPD in the non-smokers. They are the genetic factors, the long-standing asthma is a very important thing to consider, uncontrolled chronic asthmatic, and environmental tobacco smoke, outdoor air pollution, particularly from traffic and other sources, biomass smoke, very common in our culture, occupational exposures, recurrent respiratory infection in the early child is another very important factor, pulmonary tuberculosis, socioeconomic status, female sex, and the age over 65 years. All these risk factors are recognized as the causes of non-smoking COPD. We'll come a little more detail in the different the type of etiological causes, whereas when you talk about occupational exposure, in the previous study I highlight, two studies carried out in the United States found that never smoker 31.1% and so the increased risk of occupation exposure to vapors, gases, dust or fumes with a job exposure matrix. Another study conducted in Switzerland has shown the biological powder, mineral powder, gas and vapors and vapor gas and fumes are very, very important. Another study, similar study conducted in Sweden had an odd ratio of 1.8, but again they have found that increased prevalence of COPD in the non-smoking group, gas, dust or vapors. So it is a universal, even in the developed world. These occupational risk factors are very important. It has shown that here again, the COPD and the gold criteria more than 2 has shown the increased risk factor due to these various occupational exposure. This adjusted incident rate ratio and in this particular study has shown the same conclusion coming into the different biological dust as well as various occupational risk factors are important in the non-smokers comparing the COPD. Biomass fuel is another very, very, very important the causative factor in causing the COPD in the non-smoker. And several studies published in the world literature, where the Spanish study, they have shown that combined use of wood and coal significantly raise the risk of COPD or ratio of 4.1. Another study conducted in Turkey found that 23.1% COPD cases would be attributed to the exposure to the biomass. Another study in Mexico and India has shown that, and India particularly, Indian study conducted by Mahmood et al. And found that 54% of the increased risk in this particular cohort causing the COPD due to biomass risk, the significant 0.0011. Further, this Mahmood study has found another important factor like a low socioeconomic group, biomass smoker, and the pulmonary tuberculosis and chronic asthma are the other important causative factor which I have mentioned previously. Passive smoking is very important. Passive smoking exposure in the adult are very important causes, and it's a dose-response relationship where it is exposed both at home and at work as a combined effects of causing the COPD. Now, you don't need necessary to smoke, but if you're exposed to passive environmental smoke are a very important cause. Another study, Jordan et al. in 2011 and found the increase in passive smoke exposure independently associated with increased risk of COPD. And COPD and exposed passive smoking at home and the workplace, as I mentioned, has a combined effect, a very high odor ratio of a significant causative factor. It is showing again the number of smokers living in the same household as well as the duration are important factor. So again, this study of Jordan has shown the same finding. This hashtag study also showing the same associated environmental tobacco smokes and COPD smoke. And another important factor, as I said, is the chronic asthmatic. Chronic uncontrolled asthma is a very important risk factor. And dengue studies published related to COPD smoking found that this chronic asthma are a very important risk factor, and the sigma rate was less than 0.01 was in the COPD in the non-smokers. And this Mahmoud study I mentioned previously has shown the long-standing asthma is one important factor. And why asthma causes in the COPD? What is the reason? There are many pathophysiological mechanisms highlighted. One is a persistent airway inflammation and the remodeling leading to non-reversible status of airways. And environmental exposure triggers with uncontrolled asthma is a further worsening of a pathological situation leading to COPD phenotype. And the age-related changes and disease progress, if you are chronic asthmatic, uncontrolled, when you're becoming aged, and that is further developing to the COPD phenotype. Other important is a potential misdiagnosis or overlapping feature. You can have a COPD asthma together, or these are same genetic predisposition. And as a genetic factors and susceptibility. Genetic predisposition may make individuals susceptible to both asthma and COPD, potentially contribute to the development of COPD despite an initial asthma diagnosis. So in other words, genetically driven COPD and asthma in the same individual. And the treatment-related factors are prolonged use of certain asthma medication, particularly high-dose inhaled or oral corticosteroid. They have shown that high predisposition to develop the COPD. And exacerbation and the lung damage. Recurrent exacerbation due to many causes of asthmatic can lead into this one. It's a very, very important thing. We need to consider uncontrolled asthma and who's going to develop the so-called COPD phenotype. Another important cause is the tuberculosis, a well-known association in this part. There are many publications related to this. Perez Fedila conducted study in the Latin America and shown that previous diagnosed TB was 3.36. Is a very important risk factor. There's another cross-sectional study undertaken in Korea and has shown the odd ratio of 4.5. And India has shown the very high prevalence of COPD in patients with the previous history of tuberculosis. And this Mahmoud study, which has shown previously, has shown the high significant rate. As well as, and there are many studies, it has shown the TB is a very important relationship with the goal severe COPD as well as a very poor lung function. Respiratory infection, another important cause for non-smoking COPD. Particularly the childhood respiratory infection can infect the COPD development. This is very important in our culture because our children are predisposed to the frequent recurrent respiratory infection during their preschool time and they are in the kindergarten and the so-called preschool. It has become a common practical problem we all pay day-to-day practice. Why respiratory infection leading to COPD? Due to there's a lung development disruption. As you know, our lung is developed, the total development at the age of 80, when there's recurrent respiratory infection will impair the lung development. And airway damage due to tracheobronchitis, the airway involvement leading to chronic bronchitis. Heightened vulnerability, lung damage from childhood infection can include susceptibility to environmental factor. If you have a recurrent infection, with that exposed to other risk factors, further deteriorate the lung condition compared with healthy lung. And immune system changes. Early infection might alter immune responses, promoting pro-inflammatory environment in the airway, and it will lead into the COPD phenotype. And the long-term effects of a specific pathogen can cause lasting damage to modify the immune system. And a study conducted in Tunisia showed the threefold high risk of developing COPD in the patient who had recorded hospitalization due to childhood respiratory infection. So this is a very common factor. And history of respiratory infection in childhood show in this particular Ambridge study. and showing the odd ratio of 2.21. This is showing that how the Emperor study where the childhood hospitalization impound causative factor. Genetic factors, there are many, not only the alpha-1 antitrypsin deficiency, many genetic factors are involved in the development of COPD other than smoking. Maybe genetic disorder by the mutation in the SERPINA1 gene. There are many associated AATD related genetic factors. Many protease inhibitor variants and the lung development gene, lung repair and structure, and the implant response genes, and auxiliary respiratory antioxidant gene. There are many genetic factors are important in developing onto COPD. Another important factor, very common to all of us, are socioeconomic status, and we are the developing world, due to many factors closely interrelated developing the COPD in this particular cohort. Very common in Southeast Asia, African and American, South American countries, the intrauterine growth retardation, poor nutrition, housing condition, childhood respiratory infection due to very poor house status, and exposed to tobacco smoke, biomass smoke, and other indoor air pollution and occupation risk. And all these collectively act together developing the COPD. And female sex in the studies have found that more frequent in the woman and the old age group, which has shown the previous figures, and the Lampet study has shown that how common in the women developing the COPD in the severe gold status. Age is important, and increasing age has a more predisposition, partly because of the aging as well as alteration of the structure of the lung, airways as well as lung, older than smoking, and so this is very, very important. Symptom with the non-smoker. There's no big differences as an almost same symptom, but we have learned the previous presentation, but they were less intense symptoms. So all the symptoms are almost same, and it's never smokers and never smokers. There's slight differences, and non-smokers, the less common symptom compared to smokers. Is showing the same thing, how the never smokers and ever smokers showing the different symptomatology, little less severe compared to the smokers, and showing and how lung function slight difference, but the smokers has worse compared to never smokers. And the never smokers, the COPD may have a milder symptom than both current or former smokers, as I mentioned the previous slide. And the never smoker has been the fewer symptom, milder form of the disease, and the less inflammation than the current or former smokers. Does COPD in never smoker have a different phenotype? It remains questionable and need more studies to time to come. COPD in the ex-smokers may have a different clinical and pathophysiological features because of the differential role played by multiplicity of and years of exposure, so need to find more. And non-smoking patients, the COPD have a predominantly airway involvement compared to smokers. The smokers cause both airway and parenchymal damage compared to never smokers. And it's also debatable whether an ex-smoker should be considered as a non-smoker or separate category. And there are some distinct radiological and pathological differences in these different groups, particularly biomass exposure. And what found is a significant change of the bronchitis and fibrosis, increased eosinophilic component, and the anthracotic pigment deposition, thickening of airway walls, vascular endothelium, patient with the biomass poor response. Because of the carbon particle and the smoke acting on the airways cause what we call anthropofibrosis, and where the significantly airways are involved. In the Mexican study, has shown that clinical characteristic, quality of life, and mortality to those with COPD to workers smoking are actually different. So, and what we found is the Moran and Meadows and the colleague report that women with the COPD due to biomass smoke, very common in our practice, had more lung fibrosis, greater pigment deposition, and the thicker pulmonary artery intimas because of the other factor due to the biomass pool had a soot and the various harmful gases. But when you talk about the tobacco, male tobacco and the female biomass female, the male tobacco has a worse prognosis. And our neighbor, this Sandeep Salvi's study has shown that almost same findings what we have mentioned. And diagnosis, I am not going to detail the clinical symptoms, physical examination, lung function, and imaging studies all are done. What is important to understand, the smoking COPD, the more emphysema, I told a little earlier, and the more blood formation compared to non-smoking COPD, have dirty lung because airways have become more thick and more commonly airway involvement, which can see in the chest X-ray and the CT scan. One of Sri Lankan study conducted by Dr. Kanthi Nanayakkara and al. Have found that same finding which we have mentioned in the non-smoking COPD in our society as well. So the current COPD, as you know, the group into different phenotypical, genetically determined COPD-G, COPD due to abnormal lung function, COPD-D, environmental COPD due to smoking, COPD-C, biomass and pollution, CP. So we can categorize COPD in different periods. In time to come, we can get more and more information. I am not going to discuss the management. There's not different, but most important, avoiding and getting out of this very different exposure. Treatments are almost same in like a COPD. I'm not going to discuss that. You already listened to the other speakers for COPD. So I like to conclude this presentation where there's a lack of knowledge in non-smokers. With the time to come, we will have more information related to the so-called non-smokers. There's a high heterogeneity, and because the smoking tendency, there's a decline tendency, but equally, we have to think about the non-smoking COPD group. And where is a way we need to get more and more information where the various biomarkers. And multi-center Radiforcons case control study, which is multicentric study conducted in Spain, has already included also 300 patients with the COPD and the never smoker. Might be able to give a more answer in time to come. They do the analyze in more detail. So I was not happy not to present here in person, unfortunately, because of very tight my schedule. I may not be able to present, but I'm very happy to answer online if there's a question during the question time. Thank you very much.
Thank you very much to Professor Dushantha Medagedera. In the absence of questions, we'd now like to... Just checking, do we have any questions? In the absence of questions, we'd like to end this session today. The final session, the final specialty update of the year, organized by the Ceylon College of Physicians in collaboration with the Sri Lanka College of Pulmonologists. Thank you very much for being an active audience and for your engagement and your participation. We thank the resource persons once again for generously sharing their insights and expertise with all of us in the audience today. So thank you very much. It's a goodbye from us. Take care.